Guys, I got stuck in traffic. I'm almost at the office. Give me like 5 minutes and I'll get the feed up. Also, good morning, everyone.
Great, okay. Well, we'll start with something else and then we can look. Okay, let's turn to Joann Bellissari. Did you review the records we just discussed in this lady's case?
Yes, ma'am. I reviewed the records at least 2 times in totality. First, prior to my initial report in the case, and then subsequently, about a year later, when I was asked to write an individual report on the case.
Thank you. Did you attempt to review the entire medical record?
I did, yes, ma'am.
Do you remember each and every fact from her medical record?
No, her medical record was several thousand pages. It would be impossible, I think, for any physician, nurse, or reviewer to remember every specific fact.
Okay. States Exhibit 32C, his report. Yeah. Okay. You're presenting States Exhibit 32C. What is that?
States Exhibit 32C is a copy of the report that I submitted after my review of the medical records.
And counsel, you can go back and forth without asking because you've got a lot of time.
I'm sorry, sir.
You can go back and forth without asking because you've got a lot of documents to bring up there.
We'll be at it for a while. Your Honor, may I publish portions of the report?
Any objection?
Just between us, we don't even need to sign.
No, this is the. So, or at least we can approach when we get to that point as far as what should be. Right. Oops. Is this guy on?
Should be. You gotta let it focus. It's gotta know how to focus.
It's doing absolutely nothing. I just turned it on. There we go. Yay. Okay, this is, I'm demonstrating page 2, and Dr. Schweiker, what is discussed on page 2?
So page 2 is in essence a narrative description of the patient's presentation to Mount Carmel, giving a brief synopsis of her past medical history, followed by the presenting symptoms or chief complaint. In this case, it was seizures of new onset. And then towards the bottom of the page, in a tabular form, the physician has listed key elements of her past medical history.
Okay, thank you. And is there a reason COPD is listed first?
Yes, obviously chronic obstructive pulmonary disease, or COPD, is a diagnosis that affects the patient's lungs. And so that be a major issue. This was in some of the other diagnoses that are listed below, particularly the presence of pulmonary hypertension, which is elevated blood pressure within the lungs itself.
Thank you. How long was her hospital course?
Her hospital course was from April 22nd through May the 10th, so it was a little more than 2.5 weeks.
Okay. And do you recall when this lady went to the intensive care unit in this case?
Yes, she went to the intensive care unit after she had some respiratory deterioration, and I believe that occurred on around May the 1st.
Okay. Would it help if I placed part of your record or your report indicating that Dr. Hussel was requested to evaluate her on May 1st? She was then transferred to the ICU. And what other things were going on with her as you see there?
So on May the 1st, the patient had an increase in their respiratory rate. You can see under consulting physician towards the top, it says that the patient was tachypnic, which means increased respiratory rate or breathing. The patient also had a change in mental status, meaning that the patient was confused, but still talking, and the lungs had distant breath sounds. So again, at this particular time, the patient had been placed on sodium bicarbonate to try to buffer her acidosis. And then there was a decision made to evaluate the patient in order to put the breathing tube in or to intubate, which would help the patient breathe on a ventilator. And that's listed towards the bottom of the page when it says that she had become very unresponsive and was only responding when the doctor rubbed on her chest. That's a sternal rub. And so the decision was made to go ahead and put the breathing tube in.
Okay, thank you. Then you have a note that Dr. Hussel again interacted with the patient on several days later.
May the 6th.
Yes. What does that note indicate?
So on that day, it appeared that the patient had become progressively agitated, and the patient was on a sedative known as Presidex at relatively low doses, 0.4 micrograms per kilo per hour. So upon the assessment and the fact that the patient had been agitated, and there was also concerns that the patient had regurgitated the feeds that were being given into the stomach, and there may be aspiration, which means that with vomiting or regurgitation, the patient could soil the lungs with the aspiration. So at that point, there was decision to suction the patient. They turned the tube feeds off, and the amount of sedation was tripled. It went from 0.4 to 1.4, and the patient also required more oxygen and adjustment of the ventilator. So the oxygen was put to 80%, and there was more positive pressure applied on the ventilator at +8.
Leading up to her demise, were there other procedures other than the intubation that this lady underwent?
Yes, the patient did undergo other procedures.
Could you please detail those?
So the concern in Mrs. Bellissari obviously was, first of all, that she had presented with altered mental status, and the initial concern was that she had a diagnosis known as PRES, P-R-E-S, which is known as posterior, meaning the back of undergone appropriate neurological imaging, including a CT scan to evaluate for that. The patient was also worked up for evaluation for obviously her colitis and her chronic kidney disease. So she had a series of blood tests that were done and documented in the record to evaluate her. And then because there appeared to be a concern regarding infection in the lung, she was started on
this
antibiotic
morning. They have a
therapy
court date, but I
in an
haven't seen the
effort to
magistrate
treat
court
the
yet.
underlying pneumonia.
Were there any attempted invasive procedures?
May I just review my report?
Please.
So wait, what did you say you have? You have the magistrate's order?
No, I said, I
Oh,
looked on the docket this morning, they
Yeah.
have a court date,
which is known
Yes.
as
I haven't seen the magistrate's order yet.
I have a new
EBUS,
contact.
which is when the bronchoscopy is combined with interpulmonary ultrasound in an effort to
Oh,
establish
damn it.
whether or not
Get my fucking
the
hopes up,
lesion that was found on her
bro.
CT scan actually reflected.
So she messaged him, she's like, can I stop over in the driveway and see the kids? I also need to drop off Kensley's book bag and the paper about the accident for school. She also got other papers she needs done for school. I'd really like to see them in person, even if it's just for 10 minutes, please. He's like, I'm not trying to be mean, but I want to hear what my lawyer says about it all. Once I get his advice, I'll let you know from there.
Thank you.
She's like, nothing in the order says I
was there a
can't see the
time
kids.
when, she received
It just says
the,
temporary placement.
insertion of.
Have you even spoken to an attorney yet? I honestly just want to see my kids. Could you, also, could you just connect Zaylee's phone? She has with her the Wi-Fi.
In order to administer.
I wouldn't have to message you at all. I would just like to see and talk to the kids, please.
Patients who were
Yeah,
placed
ignore
on
her.
a ventilator.
Yeah.
There was insertion.
And
of
then-
an intraarterial
So
catheter,
this afternoon,
which allowed the treatment
I am
to
gonna
be
head out.
measured
I'm leaving here probably 3:30.
blood pressure measurement,
I'm going
but
to
also
try
to
to meet
sample
him
the arterial
because she
blood
told me he doesn't
to
leave
measure
till like
arterial
4:30 to
blood
go to work.
gases.
That way, I'm gonna knock on the door and be like, "Hey, how you doing? Look, here's my card.
Pain
I
medication.
thought I gave it to you before. If I didn't, I apologize. I'd like to have your phone number.
Yes,
We
she
could
did
talk. I was told you're talking to an
intermittently
attorney,
receive low doses
What
of
attorney are you
pain
talking to?
medication throughout
Well, I
the
understand,
hospitalization.
but I called a number and I'm pretty sure I got
Was
Ryan.
there a
And I said,
time
look,
when
I'd like to speak to you. At the very
the
least, we'd like to set up
nurse
visitation.
tried to switch the
But no, I have to
side
follow
of
some rules. And I'm like, okay, well, fine. Who's your attorney?
Right.
insert-
you know,
the,
And I'll bring that up in court. Like, Your Honor, we thought he was going to have an attorney. He's jerked around. He's caused problems.
You're referring to the
Although it's almost getting to the
index.
point where I'm going to have to become a witness too.
He's a piece of shit, like.
Well, I know that, but I'm almost going to become a witness, and Stu's going to have to jump
Do you
in.
recall that?
I do recall that, yes.
Okay.
Because that way I can testify. It's like, yeah, I was her previous attorney, and he never made himself available.
So she told him, she was like, okay, Ryan, she's like, I'm not trying to fight with you. She's like, but since you're ignoring me, here is my attorney's contact information. She was like,
Put up,
just contact him and talk to him. Ignore her.
handoff form from her medical
So then
record,
yesterday,
dated May 5th.
Uh-huh.
she's like, I know you're ignoring me. She's like,
which
can you please let me know about
indicates
Kinsley's
that,
schooling? And if you hear anything about
she
Damien's spring pictures,
had some
because I ordered
agitation
Damien
and
and
that they could
Zaylee's
not
spring
change
pictures, and I'm assuming they will come home in their book bag.
or
Yeah.
change the side
I
of the
paid for those.
tube.
Can you please let me know when they come in?
Yes, so,
Mhm.
on
And can I
May
please talk to them
5th,
today,
and
please?
then again, on May 6th, there were attempts to perform what's known as
Again, he
spontaneous
ignored her.
breathing trials, where there are efforts to wean the patient from the ventilator.
So then again,
and
she
allow
was-
the patient
she texted
to
them a
do
little
more
later.
breathing.
She's like, I'm not trying to blow up your phone. She's like, I just wanted to make sure you knew about the kids' appointment since Damien missed his appointment.
Because if you leave it sit
Uh-huh.
on one side of the
She's-
mouth
and
too
she's-
long, it
She told me about that yesterday.
Yeah,
that
she resent it
flip in the gum to the
with
other
all the
side,
kids'
but as
appointments.
was
Yeah.
documented here, she did not.
And she's like, in case he tries to say I never told him, she resent it.
Yes.
Become very agitated.
that was a good idea on her
In fact,
part.
at that time.
I told her that. She's like-
She said she got to talk to Kensley yesterday for maybe a couple minutes. She's like, I don't know if it's true, but he's obviously talking in front of the kids or telling the kids stuff. She's like, because when I talked to Kenny told me her dad went to see the judge today, and maybe he would let mommy see us again in 50 to 40 days. And she was like, well, who watched you if daddy went to, and she said Grandpa Lance.
Sent to you pages.
She's like, I really do not feel like he should be the best person to be watching our children, especially when we have two young daughters.
Which are the
She was like, he was in prison for years.
Lance went to prison?
Yeah.
For what?
I don't know. I checked his docket and all I seen was an OBI and some addictions, but it might have been another county because I know he didn't live around here. And she's like, Ryan's sister, Danielle.
How long ago did this? Is this Ryan's dad?
Yes.
What's it, Lance Makepeace?
Yeah. But she said, Ryan's sister, Danny, used to tell me he was weird and tried to do weird shit to her. I don't know, he molested the older sister Ashley when she was little too. She's like, I don't have any proof on anything, but I really don't feel that he's the best person to be watching our kids. I know he used to beat the kids when they were little, but I get.
Do you know all of these of your own personal knowledge and memory? Or is this refreshing?
It refreshes my memory, yes. I mean, I was generally familiar with the information, but in terms of each specific entry, I'd have to look at the chart.
Okay, thank you. And what would you say about her pain scores during the course?
So what those pages reflect was that the vast majority of the entries observed and made by the nurses is that Mrs. Bellissari had either a score of 0 or was documented to be sleeping. There were a few occasional entries where she did have a score of 8 that was usually associated with procedural interventions by the nurses. And towards the end of the document, there was one entry where they have a narrative description of pain where the nurse described the pain as burning. Again, how she identified that is not totally clear since, Ms. Bellissari had the breathing tube in eventually, but essentially for most of her hospitalization, her pain was very well controlled or non-existent.
I'm sorry, Your Honor, we had the medication administration stuff separated and I'm going to present to you what is represented in pages 2428 and 2639, which is the MAR or medication administration record. Have you previously reviewed this?
I have, yes. This looks exactly familiar with what was included in Ms. Bellissari's electronic medical record, including the detailed pages regarding the medications, and then towards the second part, the continuous infusions, which were broken out separately that she received during the admission.
So could we talk for a minute about the two parts, the continuous infusions versus the infusions or medications that are given in the regular part of the MAR.
Yes, ma'am. So when a patient is in the ICU, there's usually a distinction between those medications that are given intermittently, whether that's on schedule or requested by the patient. And that can either be through an intravenous, or it can be, if they're not intubated, through the mouth, or occasionally, even if they have a breathing tube in, the nurse can crush them and put them through the feeding tube to deliver the patient the medication. Alternatively, there are those medications that have to be continuously run into the patient. And as I mentioned, she had been on a medication called Precedex, and that medication needs to be continuous infused into the patient in order to control the patient's potential anxiety or sedation requirements. That medication itself has a half-life less than 10 minutes. So you couldn't really give it once every 2 hours or 4 hours. There'd be huge gaps in it. So whenever we talk about continuous infusion, it means that there's a pump on the patient's bedside, and it's putting through the IV tubing that constant medicine. And at Mount Carmel, consistent with what is done at other hospitals, they distinguish between the infusion of the two medications.
Thank you. Did you make notes as you reviewed the medication administration record of medications that were administered that you felt were important to note in coming to your conclusions?
I did, yes, ma'am.
Was this lady on continuous infusion of pain medication?
No, she was not. She would receive intermittently when needed. She would receive IV bolus of pain medication. And then the infusion involved the Precedex, which primarily was used for sedation. It does provide a small amount of analgesia, but it's not primarily used as an analgesic medication.
Which physicians cared for Ms. Bellissari in the intensive care unit at Mount Carmel West?
So obviously the admitting physician cared for the patient, and then I saw consultations by gastroenterology, Dr. Reddy. There was also Dr. Zangmeister, who was a hematologist, Dr. Agra, who was a kidney doctor that saw the patient. I also saw documentation in the record from obviously Dr. Hussel and the critical care team. So there were multiple treating teams that were providing consultation for the patient.
Thank you. Was this lady extubated on a certain date? And if so, what was that date?
Yes, she was ultimately extubated on May the 10th, 2015, when the breathing tube was removed from her airway.
Thank you. And was there medication associated with that extubation?
Yes, there was. Earlier that evening, shortly after, I think it was around 6:26 in the afternoon, she did receive Dilaudid for prescribed breakthrough pain, but it was a small dose of 1 milligram. And then later that night at approximately 11:32, which is 23:32 military time, Ms. Bellissari received 1,000 micrograms of fentanyl intravenously.
Is that detailed in your report?
It is, yes. On page 7 of the report, I described earlier orders regarding fentanyl. Those were those that were received on April 30th and May 1st. And then the actual medications for the intubation were on page 8. And then lastly, what you had asked me, the medication received prior to the extubation was detailed on page 9 of the report, where I indicate the order placed for the 1,000 micrograms of fentanyl and the nurse confirming the administration.
Thank you. And who ordered that?
The order for the fentanyl on May the 10th, 2015 was Dr. Hussel.
Thank you. In your professional opinion, which we established yesterday would be within a reasonable degree of medical certainty, do you believe that it was appropriate to place this lady in the ICU and intubate her?
Yes, most certainly. Based upon her initial presentation and problem list, particularly the change that occurred in her brain, and then the subsequent workup that she was having to rule in or rule out the lung malignancy, plus her chronic medical problems, clearly by the time she was brought to the ICU, that was appropriate to stabilize her. And then attempting to place the breathing tube and putting her on the ventilator while the determination was made of her underlying medical problem, particularly the EVAS that had been done and whether there was lung malignancy or pneumonia, that was all appropriate.
Do you have an opinion as to whether or not this lady's situation was salvageable?
Yes, in reviewing Mrs. Bellissari's extensive hospitalization, it's clear within a reasonable degree of medical certainty that she had many significant medical problems, but her care was certainly not at the point where I would describe her as imminently terminal or further options futile. And so if she had been under my care, I would have continued to support her to see whether or not her condition could have improved. And then again, if at that point she did not show further improvement, then a discussion could have been had. But I didn't see that imminent death was pending at the time the decision was made for the terminal extubation.
Thank you. On page 11 of your report, there's a paragraph, diagnosis during hospitalization. Can you talk a little bit about what's in that paragraph?
Yes, so as is demonstrated on the screen, the doctor that was providing the discharge summary listed some of the major medical problems that the teams were dealing with. Starting at the top, it lists acute on chronic hypoxic respiratory failure. And that's a common term we use in the intensive care unit. The chronic respiratory dysfunction relates to her chronic obstructive pulmonary disease or emphysema. And what this term means that she had the acute exacerbation or deterioration on top of her underlying disease. And so that's why she was transferred back to the ICU on April the 30th. And then underneath that, the notation about having the breathing tube placed on the following day, May the 1st, intubated. And there was also the description which explains additively why she needed the support on the ventilator, because remember, she had chronic kidney disease, and so she had problems excreting fluids. So they list here that she had renal failure, which had worsened. Also, there was concern about associated pneumonia while she was in the hospital that they talk about, and they couldn't exclude the fact that she had aspirated the tube feeds, meaning material from the stomach coming up in the mouth and then getting in the lung. So that was all listed there. There was also, because she had a cavitary lesion in her lung, and they couldn't exclude whether that was a tumor with cancer or whether or not she had tuberculosis at some point that may have activated. The term mycobacterial infection refers to that. Below that, very importantly, they list that she had elements of septic shock. And again, this goes back to the theme I discussed. When we use the word septic, it relates to infection, and shock means the dysfunction within the body as a result of the infection. They were attributing that pneumonia. And then again, they reiterate the point about the hospital-acquired or healthcare pneumonia and possible aspiration. The identification when they cultured her sputum in the lab, they did grow a bacteria species, which was known as Echinella, and that can cause pneumonia. And she had been receiving antibiotics for that. They then also finally list two other important features that were related to her initial admission. The first being seizures, which was being treated by the neurology consultant with an anti-seizure medication known as Depakote. And that was important because although Depakote is very effective at controlling seizures, it can depress a patient's mental status and make them very somnolent and sleepy. So until they're used to Depakote, it can give the impression that the patient is not very responsive. So that may need to be controlled. And then, of course, she had the posterior reversible encephalopathy syndrome, or PRESS. And the key issue, PRESS obviously occurs because the patient's blood pressure is out of control. So that causes abnormal pressure in the brain. And as the title explains, it's reversible. So although it's severe, you have to first control the blood pressure and then allow time for the swelling in the brain to go down. And so they list that that was related to uncontrolled BP. And also she had been on some immunosuppressant medications for her rheumatoid arthritis. And there was some discussion whether or not that also may have impacted some of the additional diagnoses that were described above. For example, if you're immunosuppressed, you're more likely to get infection or have a tuberculosis that otherwise would lay dormant come out. So they had stopped the immunosuppression on this hospitalization, but again, it had not been off for a long period of time.
Thank you. Aside from that issue, did you find that some of the procedure used leading up to, do you have an opinion as far as the procedure used actually leading up to the extubation?
Yes, I do have an opinion.
What is that opinion?
So in reviewing the chart, I noted that there was no clear documentation on the day of the terminal extubation regarding a status update given her condition. And there appeared to be a relatively quick decision for terminal extubation, even though for the most part, her condition through the hospitalization, with certainly the deterioration around April 30th and May 1st that required the intubation, had either shown some improvement, such as with the changes in her brain, or had shown some stabilization. So again, the lack of a detailed progress update and the lack of a multidisciplinary discussion, given that there were multiple consultants involved in her care, appeared to be inappropriate at that period of time. Also, Ms. Bellissari had received small doses of fentanyl when she came to the ICU, and additionally a dose of fentanyl for the intubation that was much below the order for the terminal extubation. And again, in terms of potential pain or discomfort, putting the breathing tube in is much more painful than removing the tube, which often has no pain at all.
Thank you. Was a discussion of this lady's DNR appropriate?
Yes, certainly. I believe that the decision to discuss the do not resuscitate status of the patient, given the numerous medical problems, and of course, that in fact was appropriate. And I think to establish that with family or next of kin certainly was appropriate during her ICU admission.
Thank you. Is it your opinion that the extubation itself was appropriate?
No, that is not my opinion. In terms of at the time that the extubation occurred, again, I don't believe that all medical interventions had been exhausted or that the patient had been given an ample time to declare herself whether or not her conditions could be reversed.
Had she just completed a course of antibiotics the day before?
Yes, that's correct. And as mentioned in my earlier response, she had finished the Zosyn. She had a 7-day treatment. But given what was described in the record, both by pulmonary as well as the other consultants, about potential for tuberculosis, obviously tuberculosis is difficult to diagnose, even with immunosuppressive therapy, and even more difficult to treat. It usually requires months of treatment, not simply a 7-day course of antibiotics. So absent a definitive diagnosis of both the lung mass, which, as I said, the initial impression was it was not a malignancy, but there was still concern that that was missed, and or that she may or may not have ongoing infection of the lung, including both the concern about the aspiration pneumonia, which is contamination from above, as well as the concern about mycobacterium or tuberculosis. This would not have been considered complete or adequate treatment.
Turning now to the actual extubation. At what level of anesthesia would this woman's pain be appropriately addressed before or during the extubation?
So again, in terms of the adequate layer of analgesia, there were multiple entries in the medical record from days earlier that her pain was well controlled with very small amounts of fentanyl or Dilaudid. And again, then in reviewing the pain scores that were described, it certainly appeared that for most of her ICU admission, she had either no pain or sleeping or just intermittent breakthrough pain. So one would anticipate that standard doses of analgesics would have been more than adequate to control any theoretical pain that she may have had related to the extubation. And again, although there was a concern about cancer, she did not have a diagnosis of cancer, nor was there any description in the days or weeks leading up to the extubation that she had any pain related to cancer.
Thank you. What would be accepted medical practice in your hospital or in your practice as far as the actual dose?
So in terms of my practice and at my hospital, we would have started by giving her, if we had agreed with the policy and protocol I mentioned earlier, everyone was in agreement to proceed, a administration of 2 to 4 milligrams of morphine would have been a good starting point, or alternatively administer 1 to 2 milligrams of Dilaudid, especially since she had tolerated 1 milligram of Dilaudid earlier. That would have been preferable in terms of her pain relief. If the choice had been made to give her fentanyl, then given her age, her underlying kidney function, a dose of approximately 100 micrograms, which was similar to what she received in the earlier phase of her hospitalization, and what would have been 1/10 the dose that was ultimately given, should have more than adequately controlled any pain she may have experienced.
In your opinion, would a reasonable and prudent critical care physician trained in anesthesia know the effects of the drug given to this lady at this dose level?
Yes, absolutely. In terms of what a reasonably careful and prudent anesthesiologist would learn early in their training, within the first month of our education, we are lectured and expected to learn the pharmacology of the narcotics or opioids. So certainly anyone who had completed an anesthesia residency would be familiar not only with the pharmacologic effects of the drug, but the appropriate dosing of the opioids moving forward.
Was there any legitimate medical reason for this dose of fentanyl in this woman?
No, in performing a careful prospective review of the events that occurred on May the 10th, I could find no medical justification for the administration of fentanyl at 1,000 micrograms at the time the decision was made to terminally extubate Mrs. Bellissari.
What purpose could this dosing serve at this level?
Objection, Your Honor.
I'll permit it.
Thank you.
Given her underlying medical history, given the events that had occurred during the 2.5-week hospitalization, and the fact that there was no true medical justification for a dose of 1,000 micrograms of fentanyl, the only pharmacologic effect that one would anticipate is central suppression of the respiratory cycle within the brain, because again, fentanyl's onset in the brain occurs within 1 to 2 minutes, resulting in central apnea, which would then blunt the patient's ability to breathe, and also blunt the ability of the patient's brain and lungs to respond to a buildup of carbon dioxide, which would otherwise trigger breathing. So at 1,000 micrograms, more likely than not, within a reasonable degree of medical certainty, a patient such as Ms. Bellissari would become apneic very rapidly. And of course, with the apnea, the inability to breathe, death would be imminent within 5 to 10 minutes.
In your opinion, did the dosing of 1,000 micrograms of fentanyl hasten and/or cause her death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, the decision to administer 1,000 micrograms of fentanyl, which was, I believe, received at 11:32 p.m., did cause and/or contribute to the hastening of Ms. Bellissari's death through respiratory suppression, apnea, and then eventual cardiopulmonary cessation approximately 8 minutes later at 11:40 p.m.
Thank you. I'd like to approach the bench, Your Honor,
You may.
with counsel.
Jason, would you be kind enough? Is Jason entertaining, guys? No? The jury's still out on you. Okay? Okay. You ready, Madam Court Reporter? Ms. Grubb?
Thank you, Your Honor. Dr. Schweiker, do you understand or are you conversant with the concept of the doctrine of double effect?
Yes, ma'am, I am.
And why is that?
So for two reasons. One, my undergraduate degree was in religion and philosophy. So I studied St. Thomas Aquinas and his writings. He was a theologian in the Catholic Church in the Middle Ages who first put forth the doctrine of double effect. But then in medical school, we were educated in regards to the application in medicine. So for example, there are times when doctors are asked to provide therapy that have known side effects. A good example is chemotherapy. You're giving chemotherapy in order to cure cancer, but you know it's going to cause a patient's hair to fall out. It may give some numbness or tingling in the fingers. So as long as one is guided by what's known as the rule of proportionality, meaning that the benefits of the treatment outweigh the potential risks, then the rule of, or the doctrine of double effect could be applied in terms of our choice of medical treatment or therapy.
Thank you. And what does the doctrine of double effect do to speak to the acts of a physician?
So the general principle of the doctrine of double effect always speaks to the need for the physician to do a risk versus benefit analysis. The doctrine, both when put forth by the medieval theologians as well as by modern physicians, isn't meant to just give a carte blanche that doctors can do whatever they want by the understanding that there may be a side effect, but rather going back to that concept of proportionality, using, in essence, the scales of justice. You try to weigh, are the risks of the treatment going to be more beneficial to the patient than the potential adverse side effects? So for example, you can cure cancer by giving a patient cyanide, but that means that you kill them. So that obviously, there's no proportionality there. You couldn't use the doctrine of double effect saying, I am treating cancer by resulting in the death of the patient. That would be illogical, and it would not be supported by the doctrine of double effect. So there has to be a concept of moderation and proportionality. And then when doing that, particularly in medicine, as we've gotten more advanced and we have more drugs, more techniques, it becomes important for doctors to weigh the risks and benefits when offered to the patient.
Thank you. In your opinion, does the doctrine of double effect have application in this case?
No, I do not believe in studying Mrs. Bellissari's medical records that the doctrine of double effect could be used as a rationale on May the 10th to administer 1,000 micrograms of fentanyl. Because again, going back to what I mentioned just a minute ago, if you look at the concept of moderation or proportionality, she had tolerated much smaller doses of both fentanyl and Dilaudid and achieved pain control. So that would be the moderation. So in order to then go and give essentially 10 times the dose that she had received earlier would seem disproportional to her pain scores, disproportional to what she may experience during the removal of the tube. And given that she had an altered mental status at that time leading up to that, it would be unlikely that she would suffer extreme pain, extreme fear, extreme agitation. So in my opinion, the doctrine of double effect is not applicable in the analysis of Ms. Bellissari's case.
Thank you, Your Honor. Thank you, Doctor. Doctor, do you have an opinion as to what actions or lack of action taken by Dr. Hussel speak to his intent in this matter?
Yes, I do have an opinion.
What is that opinion?
My opinion is that in reviewing the medical record, the lack of a formal multidisciplinary consult on May the 10th, the lack of involvement or consultation of palliative care, the lack of clear and identifiable documentation in advance of the decision to proceed with terminal extubation and removal of the breathing tube, given her medical history and course, and then the relatively excessive dose of fentanyl at 1,000 micrograms speaks to the intent of Dr. Hussel, who gave the order for the fentanyl as well as the decision to proceed with the terminal extubation.
And what, in your professional opinion, what do you believe that intent was?
Objection, Your Honor, asked and answered.
I'll permit it.
In my professional opinion, which I render within a reasonable degree of medical certainty, the only plausible explanation for administering 1,000 micrograms of fentanyl on the evening of May 10th in advance of the terminal extubation would be to result in the accelerated death of Ms. Bellissari by respiratory depression and apnea, because there would be no other plausible explanation to administer such a large dose at the time of the terminal extubation, given what was known about her neurologic, respiratory, and kidney function, as well as her relatively advanced age. It would be more likely than not, given that dose, that she would rapidly succumb after the extubation, and that, in fact, is what occurred.
Thank you. Thank you, Dr. Schweiker. We are now going to move on to the next case, which is the matter, count 2 of the indictment as alleged, be the murder of Ryan Hayes.
Wait, I'm sorry. Wait.
Count 2 of the indictment. As alleged, the murder of Ryan Hayes. That's why we're here. It's an alleged murder. Thank you. I'm going to approach the witness stand, Dr. Schweiker, with State's Exhibit 2.
Yes, ma'am.
Thank you.
So these are the medical records from the admission of Ryan Hayes, who was admitted to Mount Carmel West on April the 2nd, 2017, through the emergency room after transport by the EMS system.
Dr. Schweiger, have you reviewed these records?
Yes, ma'am. I have reviewed those records carefully in a prospective manner.
Did you also review a coroner's report for Ryan Hayes?
Yes, I was provided the coroner's report and toxicology data, meaning that they sampled Mr. Hayes's blood after death to determine what substances were found within his bloodstream at the time of death.
Okay. I'm going to present State's Exhibit 18P. Does this establish that the blood was anti-mortem?
Yes, I misspoke. So actually, anti means before death. So on the attachment of the toxicology, it actually was anti-mortem blood.
Okay. And Dr. Schweiker, did you review this document before you wrote your report?
No, I was presented that document after I wrote my report.
Okay, thank you. We'll address it in just a minute. Do you recall what Mr. Hayes's reason for going to the hospital was?
Yes, so Mr. Hayes was relatively young. He was 39 years old. He had a history of substance abuse. Apparently, he had had, I believe, dinner with his sister, with whom he was staying at the time, and then told his sister that he was going to draw bath water and take a bath. When he didn't present and she heard the bath water still running, she then investigated and found Mr. Hayes unconscious in the bathtub. So that at that point, she called EMS, who were dispatched to the home and attempted to resuscitate Mr. Hayes with both basic and advanced cardiac life support. And given his history of polysubstance abuse, I believe also administered the reversal medication known as naloxone, because they weren't sure whether or not he had taken any narcotics. They chose to give him the naloxone in an attempt to reverse him.
Thank you. And what was the length of his course of treatment?
He was admitted to Mount Carmel West on the 2nd, and he passed away on April the 4th of 2017. So it was approximately 2 days.
Thank you. On page 2 of your report, you indicate an assessment, and it indicated disposition of this patient within the hospital. Could you review that for us?
Yes, so here under the assessment, again, it mentions that under where I wrote next page, that the patient had been found asystolic, which meant at the time EMS came, he had no electrical activity on the EKG. He received multiple shocks by the EMS and also several rounds of adrenaline, which is the medication epinephrine, and then a medication to reestablish electrical stability of his heart. That's the amiodarone. And it required a fair amount of work by EMS before he returned to spontaneous circulation, that being his heart beating on its own. Both the sister who found him and then EMS were unsure how long he had been in cardiopulmonary arrest, because again, it was unwitnessed directly. So he had been intubated, and because of the cardiogenic shock, he had been started on vasopressors to support his blood pressure. And again, the patient was appropriately transferred to the ICU and was stabilized there initially. And then it was decided that the patient would not want to have chest compressions if another code occurred. So that's why DNR CCA, which means basically comfort care in the event of another arrest, was entered. And then at the bottom, they list that he had really a cardiac arrest and then acute hypoxic, meaning low oxygen respiratory failure.
Thank you. Was this individual appropriately intubated?
He was, yes. Whenever a patient is in asystole, they absolutely require support of their airway because they're going to be unable to breathe as a result of the inactivity of the heart. And then because he needed both basic and then more importantly, advanced cardiac life support, including the defibrillation and multiple rounds of medications, it was very important that his airway was in fact secured. And since the patient did not immediately regain consciousness, he needed mechanical ventilation.
Thank you. Do you find that the documentation leading up to his final day in the hospital is adequate to explain what happened next?
So in terms of the doctors who were providing consultation, there was detailed explanation regarding what they were thinking and what the treatment options were. But then in terms of the terminal decision to move to extubation, once again, there was a lack of appropriate documentation as to the thought process or the specific inclusion of the multidisciplinary approach or palliative care in the process of determining whether or not Mr. Hayes should be extubated or receive terminal extubation.
And based on your experience and knowledge, is there sufficient information in the medical record to determine that this individual was terminal?
No, given his relatively youthful age of 39, as well as that it was an unknown downtime, one would want to allow the patient that period of time that I discussed previously to declare himself. Certainly the features of his arrest pointed to an ominous outcome. You know, the fact that he didn't respond immediately to resuscitation, that he was found asystolic, and that his pupils were found in the emergency room to be fixed and dilated certainly speaks to an adverse outcome. But again, usually these patients, particularly given that his initial arterial blood gas did show relative stability and not severe acidosis, one would want to give him the benefit of several days to see whether or not he did have any life still remaining within his body.
Thank you. If he had presented in your ICU, what procedures or medications would you have employed?
So for out of hospital arrest and given his youth, first of all, we would have attempted to cool the patient with targeted temperature management in order to protect the brain from further injury or swelling. Additionally, some element of sedation to reduce the oxygen requirements of the body during the first few tenuous days, both while he's being cooled and then coming out of the cooling, would have certainly been appropriate. Aggressive attempts to control his acidosis would have been appropriate, whether or not that required just the administration of sodium bicarbonate or the institution of other means of controlling his acidosis would have been appropriate. And then, of course, detailed neurological exams to make sure there isn't an improvement in his condition. Certainly, again, the concern was for brain injury. And then if there was a concern, a detailed neurological exam, including an apnea test, would have helped guide our decision moving forward on what his prognosis would have been.
Thank you. Have you reviewed the pain scoring for Mr. Hayes?
Yes, ma'am, I have.
The pain scoring for the record, the Hayes case, appears between pages 204 and 205. I'm going to hand you those pages. Does that refresh your collection?
Yes, ma'am, it does.
What pain level was documented for Mr. Hayes?
From the time Mr. Hayes arrived at Mount Carmel West up through the decision for the terminal extubation, he essentially had a consistent pain score of 0.
And then what happened at the point of the extubation in the pain scoring?
May I just look at the document one more time?
Sorry.
I just want to give an accurate response. No, thank you, I apologize. So what occurred was that on the very late evening of April 3rd at 22:57, for the first time, his pain score was indicated to be a 10, and that was using the critical care pain observation tool, or CPOT. And then it was listed as a 10 at 2257 at 2316, again as a 10, even though the upper limit of the CPOT is only an 8. So that really made no sense to me. How could it be a 10 when the maximum score could only be an 8?
Did you review the Glasgow or RAS scores for this individual?
I did, yes.
What were those?
Mr. Hayes's Glasgow Coma scale was a 3, meaning that he had no spontaneous eye opening, he had no verbal response, and he had no motor movement to command. So that would be the lowest score that would be able to be detected on the Glasgow Coma scale. And then he had a significantly depressed RAS score.
Thank you. Do you believe a discussion of a DNR was appropriate in this case?
Yes, given the circumstances of his arrest, as well as his initial response to EMS and the concerning findings in the hospital that I described earlier, both on the neurological exam and then his essentially lack of arousal after he was admitted, I certainly agree that a discussion with the next of kin regarding DNR status was in fact appropriate, because certainly if he had suffered another cardiopulmonary arrest, it is more likely than not he would not have definitely survived that or recovered. So it was appropriate and humane to discuss the future DNR status while at Mount Carmel West.
Have you reviewed the medications given to this patient while hospitalized?
I have, yes, ma'am.
And what were those medications?
So in looking at his medications, obviously he received up until the, do you want me to look at the MARS real quickly? Or
I can, sure.
Yeah, I think that.
For the record, the MARS in this case appears at pages 399 to 415.
Thank you. So in terms of the intermittent medications, he had received sodium bicarbonate to correct the underlying acidosis. He was administered insulin on a sliding scale to avoid elevations in his blood sugar. He was given a medicine to avoid excessive acid in his stomach, known as Protonix, Protonix. And then he was also given heparin to avoid any blood clots. And then in terms of the sedative medications, he received none until the decision for the terminal extubation. And the same in regards to pain medicine, he did not receive any until the decision for the terminal extubation. In terms of the continuous infusions, that which is given every minute through the ICU, he was receiving the medication Levophed, Levophed, which is a vasopressor meant to increase his blood pressure.
And what medications were given or administered to Mr. Hayes in relation to the extubation?
So in relation to the extubation, Mr. Hayes was ordered, again, 1,000 micrograms of fentanyl. That order was placed at 10:53 p.m. And then he also had an order placed for Dilaudid at 10 milligrams, and that was placed at 10:53 p.m. And then additionally, there was an order placed for Versed, the midazolam, at 10 milligrams IV push at 10:53. And then there was an additional order placed, and that was timed at 11:15 for a second dose of fentanyl, 1,000 micrograms IV push.
Thank you. Could you determine in the medical record any reason in between those doses for the second round of dose?
No, there was apparently no specific indication other than this aberration of the pain score that was listed by the nurse, which again was inconsistent with his clinical examination leading up to that or any other pain score prior to that. But there was no description in the medical record that would have indicated a need for the high doses or the multiple administration of medications. In this case, he received 2 separate narcotics or opioids, the fentanyl and Dilaudid, but then the additional medication of the fentanyl.
May I reapproach your honor?
Certainly.
Why don't we take a break first? It's been an hour and a half. Mr. Phillips, let's call everybody up.
All right.
Ladies and gentlemen, enjoy your break, 15 minutes. We get started at 15 till. You may be seated. Ms. Grubb, anything for the record?
No, Your Honor.
Ms. Nashi?
Yes, Your Honor, but I'd like to do it once the witness is outside the courtroom.
Okay. Sir, you're excused. Remember my instructions yesterday?
Yes, Your Honor.
We'll see you back in 15 minutes. Yeah. Ms. Nashi?
Thank you, Your Honor. Your Honor, I just wanted to note, I've certainly let it go, but I think at this point it warrants putting on the record that we are getting and/or actually at a cumulative point with respect to the evidence at this point. It is 10:30, we started at 9. There's been very few sidebars to eat away at time, and we aren't even through 2 patients. Dr. Eli testified. I think the record speaks for itself as to whether and how much crossover there is in the same document shown to Dr. Eli. But Your Honor, I think at the pace we're going, over an hour per patient, I think it certainly warrants the court's consideration as to cumulative.
Okay.
Your Honor, I don't know how the state can doctor to opine unless we place on the record why he's doing it and his various reasons. He is not the same boarding as Dr. Ely. His practice is different than Dr. Ely, and he has different opinions than Dr. Ely. The opinions are similar, but they're not identical. And I feel that the state of Ohio is deserving of a full examination of our witness. This case is too important to the people of this state and to the defendant to not have a full and fair airing. I will say this, Ms. Bellissari was one of the longest hospitalized patients. She's one of the older ones and has a more complicated medical record. I think the medical record is in like 3 volumes, 2 or 3 volumes. So getting through her was important. We have many upcoming alleged victims whose stay was under a day. So those cases will go very quickly.
Okay. And look, is there something you want to add?
Not to this topic.
Okay. Looking at 403, I agree the foundation's differently in the specialty, so I'll permit it at this point in time, but you would have covered every, if this witness, I think you covered the whole aspect. But it's not cumulative at this point in time. Okay, next issue?
Yes, Judge, we at this time would like to address the improper and outrageous conduct by Ms. Grubbs in the last exchange of this witness. When she improperly started with her commentary about the murder, now I want to discuss the murder of Ryan Hayes.
Okay.
That's not a question, it's an outright argument, and it's a conclusory argument. And I was thrown back by it so much before we objected that I wanted to make sure we heard her correctly. And at that time, I brought it to Ms. Menashe's attention, who was busy retrieving documents at the time. We asked that she come over to us so we could speak with her briefly, quietly, off the record, to confirm that that's what she actually said. Ms. Grubbs, I've heard her over the course of a month speak low many, many times, but at this time, she decided to create a closing argument again and say, yes, the murder of Ryan Hayes. That's why we're all here. And so much so that utilizing the word murder 3 times in front of the jury, I think it was a outrageous outburst on her part, strictly geared towards shock appeal, and so that the jury could hear what she was saying. Now, if that kind of conduct is permissible in this courtroom, I have plenty to say to the prosecutors in between questioning, and plenty to say about Dr. Husell's innocence and how he's wrongly being persecuted in this case. And I could get up here all day and have this type of commentary, but I certainly don't think that's proper in any courtroom. And that's why I bring it up to your attention, and I ask that the prosecution be admonished for such behavior, and that it not be permitted to happen again. And we would also ask that the jury disregard Ms. Grubbs' extrajudiciary comments, because they're not in the line of questions. They were completely improper and borderline prosecutorial misconduct.
Okay. Well, factually, she said alleged murder when she was there, even though there was a pause between the two, and even though she was facing one direction and went the other direction, she did have the alleged beforehand. Okay.
It's still not a question. It's not a proper question. She's she's sitting there talking about what she's going to do about the alleged murder. I didn't hear the word alleged, which is understandable, because that's why I needed to clarify for her. But I heard the word murder, and for her, and I know there was not a question pending, and it was not in relation to a question. She has no right to get up there and give a conclusory comment about murder without asking any questions to the witness. And I think that is the issue that's improper here.
Okay. This was the directional comment that she made going to count 2. I just want to make sure we're talking about the same incident.
Yes, sir.
Okay, Ms. Grubb.
Thank you, Your Honor. I did use the term alleged. It was a transitional comment, which I think we have to use to turn from one count to the next. And this is a murder trial. There are 14 counts of murder alleged. And I think we ought to be able to use the name of the crime that we're here for. So if the court feels that I overemphasized it, I'm sorry. I will make sure not to use it 3 times in a row or twice in a row. But my intention was to focus everyone on to count 2 of the indictment, which does allege the murder of Ryan Hayes.
Okay. Anything else?
No, Your Honor.
Anything else?
Yes, sir. First of all, I'm fascinated by this new evidentiary concept called transitional, which we have objected to repeatedly in this case. That aside, it does not give a lawyer the right to make commentary, which is the ultimate decision of the jury. And I agree, we're here for a murder trial. So when I ask a witness, did you conspire to commit murder with Dr. Hussel? I should be permitted to ask that question, but instead it's objected to because, I mentioned the murder word. So, you can't have your cake and eat it too. And in light of this, that it still sidetracks the main issue, which she got up there and made a comment that was a conclusory comment to this jury without a question pending. And then she came over here and spoke loudly and mentioned the word murder 3 times. And that's why we're all here for a murder case, because of the murder. And she knows that's improper. Absolutely knows it's improper. To sit here, we're trying to speak to her, clarify an issue. And she intentionally blurts out our conversation loud enough for the jury to hear. That's a problem. That's not proper conduct in a courtroom. She knows better. And while I never tried a case about her, I know enough about her background to know that she knows better. And having said that, I think it's impermissible and it shouldn't be tolerated.
Okay. In reverse order, addressing your argument, 611C deals with leading questions. Transitional questions are always permitted. Okay? I don't know what you're basing your concept on, but it's been a common practice if I'm switching subjects to be able to use leading to go into the subject to switch it. Now, as to being testimonial or anything, that's a different issue, and it's question by question, okay? Relative to her comments there, both sides have been addressing in with the concepts of co-conspirators on your side versus this murder thing. It is 14 counts of murder. The alleged murder in transition, I do not feel that that's prejudicial to you, okay? The repetitive nature is due to the number of counts. I would ask the state to not highlight it for every count. I mean, you have to transition. The offenses occurred in count 2 or something like that, but it eventually does get cumulative in effect. So let's go through it guardedly, okay? I do not particularly care for the comment about transition made by you, Mr. Baez. It's 611C, okay? Ohio Rules of Evidence. So as to any objection on that, I don't feel it's well-founded. Anything else?
The only other issue that I would ask is that she not show me documents. She knows I'm not on the floor. There's nothing I could do in reference to documents being shown. I think it's a bad look for the jury for her to be showing me documents and I have to ignore her or point her in Ms. Menashe's direction. She's done that repeatedly. If there are documents that she needs to disclose to Ms. Menashe, I ask that she do it directly to Ms. Menashe. I don't want to get in trouble with the court, and I'm trying to respect the court's rules, and for that reason, I ask that she be so instructed.
Okay. I have my rule from day one. I've told everybody, the one on the floor is the one who's involved. Was Ms. Menashe not available?
She had her back turned and was talking to, I think, co-counsel. And for context, what I was presenting was, I believe, part of the medical record, which has been stipulated, and it was a pro forma, here it is kind of thing.
Okay.
But if that's not acceptable, I stand admonished.
I have been consistent from day one. The one on the floor is the one who deals with issues. Okay? So we'll leave it at that. Anything else for the record?
Your Honor, I believe Mr. Zion wants to.
Yes, Mr. Zion?
Want to do it at noon or?
Yeah, it's nothing that we've talked about at this point. It's my understanding at the sidebar, there was some talk about the lessers and stuff, and I would just like to put that on the record and discuss that a little bit, but that's nothing we can do now. I'm sure people have a few minutes to go to the bathroom.
Okay. We will stand in recess. We'll get started at 15 till, which is 3 minutes. I think we might not start at 15 till because I know my court reporter needs a break.
Do you all want to see the MAR again? Or revisit something with? I'm going to represent the medication administration record and ask you to re-review all of the dosing adjacent to the extubation in this case.
Yes, ma'am. I'm ready.
Would you like to revisit any of your answers with respect to the amount of medication offered and administered to this patient?
Yes, so the first round of medications that was given at 10:57 included 1,000 mics of fentanyl, 10 milligrams of Dilaudid, and 10 milligrams of Versed. And then the medical administration record indicates that 19 minutes later, which would have been at 11:16 p.m., the same round of medications were given, including 1,000 micrograms of fentanyl, 10 milligrams of Dilaudid, and 10 milligrams of Versed.
Thank you. Doctor, would a reasonable and prudent critical care physician trained in anesthesia know the effects and the combination or the combination of effects of the drugs employed in this case?
Yes, a reasonably careful and prudent anesthesia and critical care doctor would know the pharmacology of these three medicines, both individually and when combined collectively, as well as the doses at which these were being given.
Is there any legitimate medical reason for these doses?
No, given Mr. Hayes's presentation to the hospital, his lack of neurological improvement during the 2+ days that he was at Mount Carmel West, there would be no justifiable medical indication to give these medications at these particularly elevated doses to Mr. Hayes in preparation for or during the terminal extubation process.
Doctor, at what level of anesthesia would be appropriate?
So given that he had essentially 0 pain scores and a Glasgow Coma scale of 3 preceding this, very low doses of opioid or narcotic would have been indicated, again, probably on the order of 2 milligrams of morphine, or alternatively 1 milligram of Dilaudid, or alternatively a maximum of 100 micrograms of fentanyl. Certainly, I don't believe any reasonably careful or prudent anesthesia critical care doctor would have given 2 opioids at the same time to Mr. Hayes. Again, given his situation, 1 would have been appropriate, and then careful observation and, if need be, incremental dosing of that 1. But there'd be no reason to give both fentanyl and Dilaudid to the patient.
Doctor, would you like to see the autopsy report and toxicology report for the anti-mortem blood again?
Yes.
Can you tell us what substances that could qualify as a narcotic, opioid, or opiate appeared in the toxicology report for Mr. Hayes?
Yes, so on the first page of the toxicology, they indicated that there was fentanyl found, and then also that there were generically opiates found. And then on page 2, they indicated that there was some element of ethanol. Of course, that's not related to opioids. They found cotinine, which is a metabolite of nicotine from cigarettes, in his blood. They did find that there was morphine present. They found the naloxone, which was the reversal agent given by EMS. And then they found carfentanil, which is a metabolite of fentanyl, in his blood. Although it wasn't quantified, they just said positive on the toxicology report.
Thank you. Knowing now the contents of this toxicology report, does that affect your opinion in this case?
No, ma'am, it does not.
Why not?
Again, because what would indicate both the need for opioids at the time of terminal extubation and withdrawal, as well as the dosing, would be the patient's clinical presentation leading up to that decision, meaning how the patient was presenting in the intensive care unit, what his Glasgow Coma scale was, what was the observed pain scores. Those are the determining factors at what dosages you would prescribe pain medication for the patient at the time that the decision was made to terminally extubate and or to withdraw support.
Thank you. In your opinion, did the dosing offered or administered to Mr. Hayes hasten and or cause his death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, both the choice of the three medications that I listed, the fentanyl, the Dilaudid, and the Versed, as well as the excessive dosing of those three medications, and then the decision to repeat them, did cause and or contribute to the death of Mr. Hayes on April the 4th. Of 2017.
Thank you. Was there any legitimate medical reason for this dose of fentanyl or these doses of medications?
No, given what is documented in Mr. Hayes's medical record, and particularly the observation of the nursing staff as to what his pain scores had been, as well as the physical examination and documentation of neurological exam, I can not come up with any medical justification for the decision to choose these medications at the time of the extubation or the dosing schedule that was applied to each of the three medications. And certainly, given that the medications had just been administered at 22:57, there's no reasonable explanation for why a decision was made to then repeat the dosing 19 minutes later.
Thank you. What purpose could this dosing serve?
Within a reasonable degree of medical certainty, the purpose of giving these three medicines in combination at the doses they were ordered would serve to essentially hasten the patient's death and demise after the breathing tube had been taken out, given that it would more likely than not, within a reasonable degree of medical certainty, result in the patient to rapidly stop breathing due to central apnea, and would most definitely impede or impair his ability at the brainstem level to respond, both to an increase in his carbon dioxide as well as a drop in his oxygen level. He would physiologically thus be unable to respond by triggering breathing, and it would then result rapidly in his death.
What actions or lack of action by Dr. Hussel speak to his intent in this matter?
So once again, the lack of appropriate inclusion of the various treatment teams with multidisciplinary involvement, the lack of consultation of palliative care, the lack of appropriate documentation in the patient's medical record as to why a decision was being made essentially in the middle of the night to proceed with terminal extubation and withdrawal of support, the lack of a specific order for terminal extubation placed in the medical record, and then the entries in the medical record concerning the choices of the medication, the dosing, all all speaks to the intent of Dr. Hussel, who ordered these medications and ultimately was responsible for the terminal extubation withdrawal of support.
What do you believe his intent was in this matter?
In my professional opinion, within a reasonable degree of medical certainty, it appears from studying this medical record and the dosing that the intent of Dr. Hussel in ordering these medications at these doses was to cause the patient to rapidly stop breathing and thus to hasten his death.
Thank you. Thank you. Doctor, let's turn the page to Beverly Scherzinger. I won't repeatedly approach. I'm holding her medical record, States Exhibit 3. Did you, in fact, review States Exhibit 3, her medical record?
Yes, consistent with the methodology I employed in the previous two cases, I carefully reviewed Mrs. Scherzinger's record prospectively, meaning from the time of admission through the course up until her death.
Thank you. To the best of your recollection, why did she go to the hospital?
So the reason that she presented initially was because she had had a progressive cough that was initially treated as an outpatient with a Z-Pack about a month previously, and she also had had a low-grade temperature. But as a result of that cough, she then had what was described as choking spells, and then she fell, and that resulted in a bruise around her calf. So she was concerned that she might have or develop a blood clot in her leg. So she presented for evaluation, and then she had had imaging of her chest at the Grove City emergency room, and that was suspicious that she might have a cancer, specifically a type of cancer known as bronchogenic carcinoma. So then she was referred to Mount Carmel West for further workup of the possible malignancy and determination as to what treatment protocols could be offered her for that.
Thank you. Did you review her various lab values?
I did, yes, ma'am.
Okay. Could you discuss her hospital course?
Yes, so after she was admitted, the treatment team realized, first of all, that she had other underlying medical problems. Most notably, she had what's known as aortic valve stenosis in her heart. She also had some stenosis or blockage in her carotid arteries in her neck, for which she had previously had surgery on the right. But most notably, they determined that she had a long-standing history of tobacco usage. She had smoked since she was 15 years of age, and that increased the risk that she actually had lung cancer. Also, there is a type of lung cancer which can result in an endocrine syndrome known as the syndrome of inappropriate antidiuretic hormone release, or SIADH. And they were concerned about that in Ms. Scherzinger because when they looked at her laboratory values, they discovered that she had a very low sodium content in her blood. And as a result of that, they needed to work that up as well. So when they determined that, they initiated medical management to try to stabilize her sodium content, but that initially did not work. So they included additional consultants on her case, including the kidney doctor and the nephrology, which is the nephrology consult, to give advice on how to bring that under control. They also included the need for pulmonary to, again, do a bronchoscopy and look inside her lung to try to better identify what type of lung cancer she had, because the CT scan not only showed the mass, but it showed she had some lymph nodes that were swollen and may infer that she had what's known as metastatic disease, meaning the cancer spreading to the lymph nodes.
Thank you. Was there a time when an invasive procedure was discussed and undertaken?
Yes, for Ms. Scherzinger, they had also been concerned, in addition to that which I've already described, that she had some lesions that appeared within her liver. And they weren't sure whether this represented spread of the cancer from the lung to her liver, or if it was just a secondary, unrelated problem. So they had worked her up and decided that rather than attempt to do a focused biopsy of the lung mass, that they would first attempt to biopsy the liver lesions, and that they would do that in interventional radiology. So rather than take her to the operating room and open her up and look at the liver, it can be done under imaging in the radiology department, where they'll pass a needle with the guidance of CT and thereby get tissue. And she did undergo that procedure, but unfortunately, post-operatively, she appeared to experience bleeding, which is not inherently uncommon, because the liver has a lot of blood flow. So when you go in to do a biopsy, that is a known risk that could occur. And as a result of the bleeding, she developed some blood in her abdominal compartment, thought likely due to bleeding from the liver, and she dropped the blood counts as well, which then resulted in her blood pressure deteriorating.
Thank you. At some point, did she go code?
Correct. So the initial hope of the treatment team was that by giving her fluids and possible blood transfusions, that the bleeding on the liver would slow down and she would stabilize. But unfortunately, then what intervened was that she did suffer what's known as a code blue and require resuscitation.
I'm going to place page 18 of your report. There's a comments section about the code. It was indicated patient in PEA. What is that?
So the initials PEA stands for Pulseless Electrical Activity. And what that means in common parlance means that when you look at the EKG, there's still electrical activity on the monitor, so it's not flatline. But when you try to feel a pulse of the patient, there's no pulse. So there's basically a disconnection between the electrical activity of the heart and the heart's ability to beat. And that's usually not directly related to the heart. It means that something else is causing it. And very commonly, it's a cause of bleeding, hemorrhage, shock, or an acute change in the respiratory status. So if you can determine what the cause of the PA is, often you can resuscitate the patient and restore the function of the heart.
Was that determined in this case?
Yes, the cause of her PA appeared to be the bleeding in her belly, which was the hemoperitoneum as a result of the liver biopsy.
And this indicates that she was transferred to the intensive care unit, placed on vasopressors, and an arterial line was placed.
Correct. So she had CPR, she had the breathing tube placed, and then not unexpectedly, because of the low blood pressure, she was placed on the vasopressors to support her blood pressure. And then they placed both a central line, meaning that they put a big catheter in one of the major blood vessels in order to give her the vasopressors and inotropes. And they also placed an arterial line to draw arterial blood gases and to measure continuously the blood pressure. So as opposed to the cuff, which goes up every 3 minutes or 5 minutes, the arterial line is hooked up into the monitor. So every second you see the blood pressure.
Thank you. Was the code status for this lady eventually changed?
It was, yes.
Okay. And at some point after the code status change, did Dr. Hussel order medication for an extubation?
Yes, correct. So again, the code status was changed, I believe, on October the 9th. October the 9th of 2017. And then thereafter, there were orders placed for the administration of 500 mics of fentanyl at 11:22 p.m. on October the 9th. And then at the same time, Versed or midazolam 4 milligrams.
Thank you. At the time that the Versed and midazolam, or the fentanyl and midazolam were ordered, had there been any paralytics administered to this patient? I can offer the NAR if you'd like to see it, Doctor.
Yes, may I see the medical admission record?
Of course. In this patient, the MAR is found at page 822 to 862.
Thank you. So I actually in the MARS don't see an entry for there, but in my report I indicate at the time the patient was intubated, the patient was given 200 milligrams of succinylcholine, although I don't see that entered in the MARS.
Okay, where would that have come up in your report?
That was on page 19.
And how do you want to handle that? Do you want to withdraw that as a comment in your report? Or would you like the opportunity over the lunch hour to maybe review more the full medical record?
Okay, is that a question?
I'm asking. It is a question, Your Honor.
No, it's not. You're giving choices, sustained.
Okay. Would you then like to, how would you like to handle that, Your Honor?
Sustained.
Yeah, so it
Okay, there's no question.
There's no
pending.
question. Doctor, do you have any explanation for why that appears in your report and not in the medical record?
I believe that to be an error in terms of the entry specifically regarding on page 24, the reference to cisatracure and ravecuronium.
Okay, so do you want to, do we then assume that you want to delete that?
Correct.
Objection, Your Honor. As as to giving her options as to how to
Yeah,
assist the court.
I agree. The jury can make whatever determination they want. They're the ones judging the credibility of the witness.
Thank you.
Have you reviewed the medications that may have been given to this patient during her procedure of 10/9?
Yes, at the time that I wrote the report, I did review the medications.
And I'm relating,
Wait, I'm sorry. Sorry, what was the question? Sorry. Could I ask for the court to read it back? With permission from the court?
You may.
I'll withdraw it.
Well,
Yeah. There was an answer, so I just want to make sure I'm hearing the question right.
let's read it back.
Question, have you reviewed the medications that may have been given to this patient during her procedure of 10/9?
That was asked and answered, Your Honor. The witness indicated he had reviewed the medical records in each and every one of these cases, which included the MARS.
Okay, thank you, Your Honor.
So I move to strike the question and the answer.
You be so strict and disregard the question and answer since he previously answered it.
Thank you. What medications were administered to Ms. Scherzinger at the point of her biopsy?
May I review the MARS one more time?
Of course.
Thank you. So it appeared in the afternoon at around the time of the biopsy, the patient had been given the medication tramadol, which is an oral pain medication, 50 milligrams. That was received at 2:39 p.m. And then approximately 18 minutes later, the patient was given 0.5 milligrams of Dilaudid. And then the patient received a second dose of Dilaudid, or at least a second dose was ordered at 15:12, although at that point, the action details, again, seem to attribute that to the former involvement of the medication that was described earlier.
Thank you. Pain score? See it closer. Did you review the pain scores?
Yes, ma'am, I did.
Is that what those are?
Yes, so this document is what's called as the direct charting flow sheet that has the pain score starting on October 3rd, 2017, up through the October 9th, 2017, the date of the death. And then below that, there is the category that's called is pain level acceptable, charting for the same period of time. And then on the subsequent pages is listed what form of a pain scale was used in order to document the pain. And then The document will also indicates where the location of the pain was, which in Ms. Scherzinger, it was identified as being essentially back pain.
Thank you. What is your opinion with regard to whether or not Ms. Scherzinger had a salvageable medical condition?
In my professional opinion, within a reasonable degree of medical probability, Ms. Scherzinger most definitely had a salvageable medical condition, given that the abrupt nature of her deterioration was immediately following the liver biopsy, which was done in interventional radiology, and had resulted in a diagnosis that we often treat, which is hemorrhage into the abdomen and anemia. That should first have been addressed to make sure that she was appropriately resuscitated from that. And then, of course, subsequently, once the hemorrhagic shock and hemodynamic instability from that was corrected, then later on, attention would have been placed to treat the underlying lung cancer, the bronchogenic carcinoma. But had I been Mrs. Scherzinger's physician, I would have counseled her family that she likely had a life expectancy of approximately a year with appropriate treatment. So again, there was not an immediate possibility of death based on the lung cancer. Again, there were treatment options that she could have been referred to. It was just the abruptness of the liver issue and the subsequent bleeding that caused her condition to rapidly deteriorate.
Did Dr. Hussel proceed to order extubation in this case?
Yes, although there was no formal order for extubation, yes, he did order it, and the process of terminal extubation was undertaken.
Thank you. What level of dosing was chosen for this patient?
So in terms of the order that was placed, Dr. Hussel ordered on October the 9th in the evening 500 micrograms of fentanyl, in addition to 4 milligrams of Versed to be given to the patient.
Thank you. Is there any legitimate medical reason for this dose or combination dose of fentanyl and Versed?
In my professional opinion, again, within a reasonable degree of medical certainty, given the fact that she just earlier that day had suffered significant bleeding from the liver biopsy and deterioration from hemorrhagic shock, there is no indication to give fentanyl at this level of dosage, nor to give the Versed, particularly since even prior to the biopsy, the vast majority of her pain scores were very, very low or non-existent. There would be no clinical reason to give these dosing, particularly since she had required the addition of both Levophed, the vasopressor, and epinephrine, adrenaline, to resuscitate her after the code blue. Then more likely than not, these medications would have a deleterious effect on her ability to sustain respiration moving forward.
Thank you. In your opinion, did the dosing of the fentanyl and Versed hasten and or cause for death?
Yes, in my professional opinion, the administration of fentanyl at this dose, 500 micrograms, coupled with the simultaneous administration of the Versed at 4 milligrams, given her medical history, which included the lung pathology, which was the lung cancer, and the events that I described earlier regarding the liver biopsy, the bleeding, the shock, and the code blue, most definitely did hasten Ms. Scherzinger's death on the evening of October the 9th.
Thank you. In your opinion, does the doctrine of double effect have appropriate application in the matter of Ms. Scherzinger?
In my opinion, the doctrine of double effect is not applicable to Ms. Scherzinger because, again, there was no attempt at appropriate moderation, meaning giving the patient medications at a lower dose, or at proportionality, meaning to essentially try to support her and resuscitate her from the hemorrhagic shock that led to the cardiac arrest, and then see whether or not she could be stabilized and from there come out at a later date, then to discuss with her or her family what treatment could be offered for the lung cancer. So again, in this case, the orders for the fentanyl and Versed were excessive and out of proportion with what she had needed prior to that or would need for terminal extubation. So again, it would, in my opinion, professionally be a violation of the doctrine of double effect because the risks would greatly outweigh the benefits.
Thank you, doctor. What actions or lack of actions taken by Dr. Hussel speak to his intent in this matter?
So first of all, I believe the hasty decision to proceed with terminal extubation and withdrawal of support that evening when she just recently had the deterioration speaks to intent. Again, secondly, the failure to involve palliative care medicine, because this is a case where, based on the high likelihood of the bronchogenic carcinoma, there would have to be a discussion about what end-of-life decisions would need to be made. And again, many of these patients can be stabilized and be then eventually discharged to hospice, whether that's home hospice or inpatient hospice, so that option should be given. And then again, really detailed explanation of the thought process as to why there should be a rapid withdrawal of support, given that her deterioration had occurred simply on that day.
And what is your opinion insofar as his intent?
In this case, based on the totality of the evidence in the medical record, it appears that the intent of Dr. Hussel was to hasten the patient's death by the administration of the fentanyl 500 mics, the Versed 4 milligrams, and then the progression to terminal extubation with then the withdrawal of life support.
Thank you. Mayor. Okay, thank you. Thank you. We're now going to move on to the matter of Danny Millette, which I believe is count 4. Thank you. Doctor, what is the presenting problem with Mr. Millette?
So in Mr. Millette, he had been transferred to Mount Carmel West with an acute change in his mental status. Of importance is the fact that he had underlying significant peripheral vascular disease that affected his legs. So he had developed in the preceding period of time a gangrene of his right great toe, and that had been amputated. So he had been in the hospital and had then been, once stabilized, he was transferred to what's known as an extended care facility for essentially continued treatment of the possible infection and blood flow problems of his lower extremity, as well as to try to strengthen him. But while there, he had this abrupt change that the wife found him unresponsive, and as a result, he was then transferred to Mount Carmel West for evaluation.
And doctor, did you review Mr. Millette's medical record in this matter?
Yes, ma'am, I did.
Thank you. How many days was Mr. Millette in the hospital?
Mr. Millette was essentially in the hospital. He was brought in on December the 5th, and then he was terminally extubated later that night. So in regards to his final admission, it appears he only had 1 day of hospitalization.
Okay, thank you. And what occurred during that hospitalization?
So unfortunately for Mr. Millette, he suffered a series of cardiopulmonary arrests in which it appeared that the infection that had impacted his lower extremity, had caused him to go into a septic shock-like state. And then his heart stopped several times, requiring resuscitation. And of course, as part of that, he was then intubated and put on a breathing tube, and he required the use of vasopressors.
Doctor, stop a
Let's hold
minute.
on for 1 second.
I actually don't think I touched anything. Any clue as to
Well, I'm trying.
what I should do?
There we are.
Thank you. Sorry. Could you read back the last question response before the flashing?
Question, what occurred during that hospitalization? Answer, so unfortunately for Mr. Millett, he suffered a series of cardiopulmonary arrests in which it appeared that the infection that had impacted his lower extremity had caused him to go into a septic shock-like state. And then his heart stopped several times, requiring a resuscitation. And of course, as part of that, he was then intubated and put on a breathing tube, and he required the use of vasopressors.
Thank you. Doctor, do you have an opinion as to the scope of his medical problems?
Yes, I have an opinion regarding the scope of his medical problems.
And do you feel that, given the scope of his medical problems, that he had a salvageable situation?
Yes, certainly Mr. Millett was critically ill. He had multiple medical problems that justified admission to the intensive care unit. But again, given the circumstances that there was an identifiable cause and that the cardiologist who was brought in on the case felt that this was not a primary heart problem, but rather secondary to another problem, which in this case was the infection that would have been contained in his lower extremity. And he had suffered abnormal blood chemistries and acid-base disturbances. Certainly he warranted ongoing resuscitation to see whether or not his conditions could be stabilized, and the multi-organ dysfunction that was determined by the ICU doctor, Dr. Duffy, could in fact be reversed.
Thank you. Did you find indication in the record that this gentleman was experiencing pain or distress?
No, in fact, the opposite. In reviewing his record, and likely because of not only the suddenness, but the numerous cardiopulmonary arrests, Mr. Millett was definitely in a coma. So I would describe him as comatose, and there was no indication that he was demonstrating any form of pain or suffering at the time that he was brought into the emergency room or the ICU.
I'm going to present pain scoring to him. I'm going to present Mr. Millett's pain score information, which appears at 342 to 348 in the MAR. What do you find there, doctor?
What I find is consistent with my prior answer, that Mr. Millett was documented to have a 0 on the pain score. The nurses that cared for him during the day did not find any indication of pain. Also, his Glasgow coma scale was at 3, the lowest it could be, meaning he was in fact comatose. And at the time that he was examined, his pupils were non-reactive. They were 5/5. So again, all of those findings are consistent with a patient who remains in coma. And it was not until the evening of December 5th that there was one entry by a nurse that corresponded with the administration of the medications for terminal extubation, where he was given a 10 on the pain scale. But everything preceding that was a 0.
Doctor, do you feel that this extubation was appropriate?
In my professional opinion, it is my opinion that this extubation at this point in his care was not appropriate, since all appropriate resuscitation measures had not yet been exhausted.
What dosages were offered to him at the point of extubation?
So Mr. Millett was ordered and then received 1,000 micrograms of fentanyl. He received 4 milligrams of Versed, and he also received 2 milligrams of Dilaudid.
Thank you. Was there any legitimate medical reason for these dosages?
In my professional opinion, expressed within a reasonable degree of medical certainty, given that Mr. Millett was clearly comatose, that he had no interact or reaction to either physicians or nurses that day who had examined him, that his pain scale had been a 0, that he had a Glasgow coma scale of 3, that he was basically demonstrating by all manners of diagnostic ability a coma and comatose. I can think of no medical justification for administering these 3 medications at the dosages that were prescribed by Dr. Hussel.
What purpose could this dosing serve at this level?
There certainly would be no medical justification of giving a patient 2 opioid medications when they were in coma and they were not experiencing or documenting pain. Similarly, if a patient is in coma, it would be impossible to assess whether or not the patient had anxiety or fear. So a sedative hypnotic when you're already in a coma is not medically justified. So the only plausible explanation for administering fentanyl, Dilaudid, and morphine would be to hasten the patient's death by interfering with their ability to breathe spontaneously once the breathing tube is removed and the patient is taken off of life support.
In your opinion, did the dosing in this case hasten and/or cause his death?
Yes, in my professional opinion, the administration of 1,000 micrograms of fentanyl coupled with the Versed and the Dilaudid rapidly served to depress Mr. Millett's respiration. And then the concomitant removal of the breathing tube and life support then accelerated his death because he could no longer breathe, particularly given that he had had all those attempts at resuscitation earlier in the day.
In your opinion, does the doctrine of double effect have application in this case?
No, in review of Mr. Millett's record, the doctrine of double effect is not, again, applicable because, first of all, he had not, or the doctors had not exhausted the maximum medical therapy to see whether or not his condition was reversible. And equally important, had not given Mr. Millett enough time to declare whether the underlying conditions themselves were terminal and care was futile. Secondly, since there was no medical justification for giving 2 powerful opioid medications in a patient who previously was clearly in coma and unconscious, the doctrine of double effect would not support then giving these medications because, again, it shows no moderation, there's no reduction in dosing, and it's out of proportion what the patient himself would need for any reasonable or prudent decision to try to avoid pain on terminal extubation, which, again, generally is not painful. And lastly, the administration of Versed in combination with the opioids would more likely than not result in respiratory depression, which again, in this situation, would not be supported by doctrine of double effect because it would overweigh the risks, that being respiratory depression, versus any potential benefit.
Do you feel that this procedure was an emergent procedure?
No, in studying Dr. Duffy, one of the pulmonary critical care's progress notes, it was clear that a well-established plan of how to support Mr. Millett was entered into the medical record, and they were planning to support him on the ventilator with the current vasopressors and see whether his underlying metabolic condition could be corrected and that he would be reevaluated the next day to then have a multidisciplinary discussion with the family on whether or not life support should be withdrawn. So to move hastily in the middle of the evening to terminally extubate and withdraw support would seem to have no medical justification when the team that had performed the comprehensive critical care admission had clearly laid out the plan in the medical record.
Thank you. What actions or lack of action by Dr. Hussell speak to his intent in this matter?
So, first of all, the lack of definitive communication with the admitting and critical care consulting team who had initially evaluated him and had established the plan, and the need for reevaluation on the subsequent day shows intent. Secondly, the failure to obtain appropriate consultation with palliative care, even if that consultation would occur on the next day when there was the plan to talk about the chances of a survivability. The decision to order 2 powerful opioid medications when Mr. Millett was not demonstrating any pain. The addition of the Versed when he clearly was a Glasgow Coma scale of 3 and all his physical findings demonstrated that he was comatose and thus would not be processing any fear or anxiety. And also then the relative hasty decision to proceed with a terminal extubation in the middle of the night when more likely than not it would result in his rapid death all speaks to the intention of Dr. Hussell in ordering these 3 medications at the specific dosages they were ordered.
What do you believe the intention was in this case?
In my professional opinion, having studied Mr. Millett's record, the intention was to rapidly terminate Mr. Millett's ability to breathe on his own and thus result in a hastened death after the breathing tube had been removed and life support had been terminated.
Thank you. Dr. Schweiker, let's now turn to the matter of Brandy Mcdonald, which I believe is count 5. What was Ms. McDonald's presenting problem?
So Mrs. McDonald had been diagnosed years earlier with a rare form of ovarian cancer, and that cancer had at the time been found to have spread into her abdomen. So she had undergone a total abdominal hysterectomy and removal of her ovaries, as well as multiple tumor debulkings in order to control the ovarian cancer. She had also been given chemotherapy and had entered approximately a 3+ year period of remission. Unfortunately for Ms. McDonald, it appeared the ovarian cancer had returned, so she was enrolled in a new research protocol, and she was given new chemotherapeutic agents, and this is nivolumab, Nivolumab. As a result of that, one of the known side effects is that it can injure the patient's liver. And it is thought that that's what's known as an autoimmune reaction of the chemotherapy on the liver. Autoimmune means the body is sensitized and then sees parts of itself as foreign and attacks it. So there was concern that she was having a liver injury, and thus she was brought to the hospital both to work up the status of her liver, but also to evaluate the remainder of her organs, given that she had some additional medical problems.
Thank you. And doctor, did you review her full medical record?
I did, yes, ma'am.
I'm going to present to you States Exhibit 32G and direct your attention to the overview comment. On the front page. Is there a typographical error?
Yes, as one would note, I think I used the template and there is a typographical error. It lists Francis Burke, but again, this is the report for Brandy Mcdonald, so that was just a typographical error.
Thank you. And is Brandy Mcdonald's name listed 3 times at the top of the report?
Yes, it's listed 3 times at the top of the report, above where I made the typo, and then on each successive page, it's listed at the top of the report on each of the pages of the report.
Okay, thank you. So what was Ms. McDonald's course in the hospital?
So initially, when she was brought in, again, the concern was regarding her liver and the fact that she had elevated liver enzymes. And as I noted on page 3 of my report, she was actually a full code, that she wanted resuscitation and she wanted to be supported through that process. As she went through the process, however, she did demonstrate instability, and she had a worsening respiratory component to the point where on January the 14th of 2018, the patient appeared to have a cardiopulmonary decompensation and arrest and required Dr. Hussel to place an endotracheal tube and put her on the ventilator. And he had administered 2 milligrams of Versed and 200 milligrams of succinylcholine and was able to successfully intubate the patient. Because there was concern about autoimmune hepatitis, the decision of her treatment team was then to administer high-dose steroids to try to reduce the inflammation in her liver. And that was then undertaken throughout the hospitalization. And she was then going to be started on prednisone, 120 milligrams through that. Her serum lactate did increase, as well as her liver enzymes. And at one point, they did send her down for a study because there was concern that she might have emboli in her lungs, what's known as pulmonary emboli. And that was confirmed that she had bilateral pulmonary emboli. And then eventually, she had been on a medication that is used for a lot of people that have type 2 diabetes. It's called metformin. And that medication, oral hypoglycemia, can result in acidosis if the body goes into shock or other problems occur. So she developed a worsening metabolic acidosis, and it was thought that it was likely contributed to by the metformin. So she was then placed on essentially continuous dialysis in order both to control her volume status, but also the dialysis machine could purify the blood and correct the underlying metabolic acidosis.
Thank you. As you review her situation, do you feel that she had a salvageable medical condition?
Yes, within a reasonable degree of medical probability in the short term, which is related to this hospitalization and the impact that the toxicity of the chemotherapy had on her liver, and the fact there also appeared to be impact of the metformin. Clearly, there would have been salvageability to have stabilized her medical condition and, again, allow her to get into a position where then discussions could have been had with her and her family about eventual wishes regarding either home hospice or inpatient hospice. Again, clearly in terms of her underlying ovarian cancer and the metastases, that did paint a difficult situation in the next couple of weeks or months. So certainly that needed to be discussed. But in terms of what actually brought her to Mount Carmel on January 11th of 2018, and then the decompensation, those were all issues that are routinely treated by critical care teams in an ICU.
Was she appropriately placed in the ICU?
Yes, given, first of all, the complexity of her medical problems and the fact that she had been undergoing chemotherapy, those are high-risk patients. Their immune system is impaired. They can easily get infections, so they warrant admission to the ICU, both for surveillance and then for potential treatment. Also, her body habitus, even though that she had undergone the abdominal surgery in the past, she was morbidly obese, and so that also factors in that she benefited from careful observation and treatment. And then, of course, because both her liver and then her kidney were showing signs of deterioration, it was justifiable to have her in the intensive care unit for ongoing treatment.
Was intubation appropriate?
Yes, at the time that Dr. Hussel evaluated her, I most definitely support his decision to intubate her. She needed to have, at that point, the tube. Not only was there evidence of multi-organ dysfunction, but as I mentioned earlier, there was this issue about the multiple pulmonary emboli, which again needed support in treatment. So as a temporizing measure and as a measure to provide supportive mechanical ventilation, I definitely support the decision to intubate her.
If she had been your patient, how would you undertake her case?
Had Ms. McDonald been entrusted into my care, I would have convened a multidisciplinary panel, most notably with her oncologist who had been guiding her chemotherapy, to fully understand what the prognosis of this ovarian cancer that had recurrence was, and what the likelihood of this new, essentially, treatment protocol could offer her. Because again, as a critical care doctor, we deal with cancer patients, but we do not administer or manage chemotherapy. So that is really outside of our area of specialty. So we need to get input from the oncologist in terms of both the life expectancy related to this cancer, as well as the treatment, which again, in this case was advanced. This was specialized treatment. Additionally, getting input from gastroenterology regarding the liver and whether or not the liver could rebound with response to the steroids, and then input from the kidney doctors about the effect of the dialysis would all have been very, very important. So this is the type of patient, given her youth, the fact that she had a relatively young child, and that she had expressed desire for full resuscitation, that I would convene such a conference and have a deep drill down into her medical situation. Obviously, ultimately, the critical care would orchestrate that. I, as mentioned, would also include in those discussions the palliative care team, because it would be important not only to address the short-term prognosis, but then her desire for long-term issues, both in regard to palliative care as well as potential long-term issues of hospice in that setting. And then, of course, I would have continued to support her for several days to see whether her organs showed improvement. If the liver and the kidney continued to show further deterioration, and or her heart and lungs continued to show deterioration, certainly I would have discussed potential palliative care later on. But at the time the decision was made, I believe it was too hasty to conclude that there was no hope for her treatment or support.
Thank you. At some point, was there discussion of going to a DNRCC? Correct,
yes. So then eventually there was an order placed in the chart on January the 14th at 10:13 in the evening to change her status from full resuscitation measures over to DNR comfort care.
Pain scoring for Brandy. Did you review the pain scoring in this case?
Yes, ma'am, I did.
And for the record, the pain score on Ms. McDonald is found at page 288 in the medical record.
Thank you.
Thank you. What does the pain scoring reveal?
So from the date of her admission on January the 11th through January 14th, she had a pain score of 0. She had no pain whatsoever described by the nursing staff. Then on the early evening, I believe of January 14th, there is one entry that she had of an 8. And then that followed a 0. What followed was a 0. And then at the time that the palliative care medications were administered, she had a score of 10.
Thank you. Have you reviewed the medications given to this patient while hospitalized?
I have, yes.
Thank you. Is there any legitimate reason for the dosing that was offered to and administered to this patient at the point of her extubation?
No, in my professional opinion, based on the review of her medical records, as well as the fact that she had abnormal liver function and was requiring dialysis and had the underlying problems of her lung, I can think of no justification for the orders that were placed at the time of the terminal extubation. Also, I might just add that earlier that day on January the 14th, there was an order placed by Dr. Hussel for fentanyl 50 mics IV every hour, PRN, meaning as needed. Certainly, I am not in any way critical of that order. That was showing a judicious, small, incremental dose that the nurses could have given her if, in fact, that she needed it for pain. So I was puzzled when then later that night I saw that the order for fentanyl at the time of extubation was 20 times that. So rather than 50, which was ordered in the morning, she was then ordered 1,000 micrograms of fentanyl.
Thank you. Who ordered the 50?
Dr. Husel ordered the 50.
Okay. What purpose could this dosing at point of extubation serve?
Well, given that Ms. McDonald had little complaints or objective documentation of pain, other than, as I said, the one entry of an 8, the only plausible explanation that I could come up with as to why an order for 1,000 micrograms of fentanyl would be given would be the intent to hasten the patient's respiratory compromise and thus result in apnea, which would accelerate the patient's death after the terminal extubation and the withdrawal of support.
In your opinion, did the dosing at these levels hasten and or cause her death?
Yes, within a reasonable degree of medical certainty, particularly in review of the medical admission record of prior administration of any form of medications, as well as the order that I mentioned had been placed in the early morning hours of January 14th for the 50 micrograms Q1 hour. I believe that, in fact, the administration of 1,000 micrograms of fentanyl coupled with the administration of the 6 milligrams of Versed did hasten Ms. McDonald's death after the breathing tube was removed.
In your opinion, does the doctrine of double effect have application in this case?
No, in studying Mrs. McDonald's case, I could not see justification for the doctrine of double effect. Here again, this was a young patient with a young daughter, or young child at least, who had expressed a desire for full resuscitation and had pursued as an outpatient every form of aggressive treatment to try to manage her ovarian cancer and metastases. The fact that she had a known side effect of one of these new experimental anti-cancer drugs would not then invoke the doctrine of double effect, because again, one would want to first give a moderate attempt at management of the patient and proportionally respond. Again, by giving her such an increase in narcotic dose to 1,000 micrograms, coupled with the 6 milligrams Versed, at the time that her liver was acutely inflamed and not working, it would not be able to handle these medications or metabolize them in any way close to normal. So there would be a prolonged excessive impact of those. So that would violate any application of the doctrine of double effect. And the fact that she had the underlying deterioration in her lung, as well as the fact she was morbidly obese, more likely than not, removing the breathing tube would result in her being unable to breathe. So again, that would violate the rule of moderation or proportionality.
Thank you. What actions or lack of action by Dr. Hussel speak to his intent in this matter?
So certainly, in terms of the action, the decision to place an order for fentanyl at 20 times the dose of the prior order would speak to the intent that one was specifically trying to cause apnea and terminate the patient's breathing. Again, especially in the background of the pain scores. Also, the decision to add Versed into the decision, given the fact that she had the liver dysfunction, the renal abnormalities, the pulmonary emboli, would heighten the impact of the fentanyl, because the two of them together would make it more likely that the patient would not breathe and would thus go apneic, and given her limited reserve, would rapidly progress to death. And then again, the lack of action, meaning the failure to convene a multidisciplinary conference, having never discussed her condition with the oncologist who was managing her cancer, not talking to the GI doctors or kidney doctors who had provided support at Mount Carmel to try to temporize her. Those all speak to the intent of the individual placing these orders.
What do you believe that intent was?
In my professional opinion, the intent in this case was to hasten the demise of the patient once the breathing tube was removed, and thus more likely than not, within a reasonable degree of medical certainty, rapidly result in the death of the patient.
Thank you. Your Honor.
You finished with that?
Do you want to address that one issue with Scherzinger, or do you want to do that after lunch?
We can do that.
Okay.
We need to circle back on a previous patient, but if
Let's do that after lunch, ladies and gentlemen. Let's come back at 5 after 1. That gives you an hour. You guys have a wonderful lunch. Remember the admonitions. With that, Mr. Phillips?
All rise.
Have a great lunch, guys. There's probably leftover pulled pork from what I hear. Okay, you may step down. Remember the admonition before. Let's let them get out of the room.
Yes, Your Honor.
Okay, Ms. Grubb, Oh, you there? Okay.
Sorry, Your Honor.
First things first, I know we had some subjects we need to talk about. Anything for the record so far?
I don't believe so, Your Honor.
Ms. Menashe?
No, no.
Okay, Mr. Zion, it's my understanding you wanted to discuss the subject matter?
Yes, Your Honor. It was my understanding at the sidebar that the court determined that it would be inappropriate for us to try to adduce evidence as to the defendant's state of mind regarding recklessness. Just referring back to, we did solicit that information on the record from Dr. Ely. We believe that this is an appropriate subject for to be explored upon, not with fact witnesses, but with Dr. Ely and with our other expert witness, now Dr. Schweiker. The court did have a motion in limine ahead of time stating that whether or not an instruction on reckless would depend on facts adduced at trial. This is the witness to do it. This is one of two witnesses we intend to do it with at trial. So we would request the opportunity to ask this witness those questions, if not a purposeful act on part of the defendant, is it at least reckless in your opinion? So that's why we're asking, that's why we would ask the commission to do that with this witness, at this time.
But he's testified it's always been a purposeful act.
Correct, Your Honor, and so we would ask that, reckless being a lesser mens rea on purpose, would this at least be a reckless act? So we would ask that that be allowed to be asked.
But if all the evidence is shown purposely, if all the evidence is shown purposely,
Yes, sir.
why do you even get a lesser, since you basically are directed at that? That's how he was indicted. There's no reason to even address it because technically you don't even get the lesser.
Well, I think we get any lessers that are part of the greater offense if there's evidence of it at a trial. And so I think it is a reasonable thing to ask a witness, an expert witness in this case, who's you've given permission and find it appropriate to opine on a person's mens rea. If this is not, in your opinion, a purposeful act, a specific intention to cause the death, would you say that it at least is a reckless act? So, which is a lesser mens rea, and reckless is a lesser of purposeful homicide. We never indict lessers, unless it is the charged offense. And so we did not in this case, Your Honor, but we believe it is an appropriate lesser to instruct should evidence be adduced at trial. This is the witness, along with Dr. Ely, who's already testified, who did testify that in his opinion, if it wasn't purposeful, it was at least reckless. And that's all we're asking for.
Response?
Honor, it's my understanding, having read the reports, that this expert is going to say that with a reasonable degree of medical certainty and in his expert opinion, that the intentions of Dr. Hussel were to hasten the death. So the question of, in the alternative, if you don't think it was purposeful, do you think it was reckless, is an irrelevant question, and I would object to it, because the testimony is, he believes that the intent is purpose, to hasten. He said that today, as with respect to all 5 patients that we've gone through so far, and he says that in every one of his 14 reports. So we don't get to the reckless or the questioning of, but for purpose, do you find reckless?
Any comment on the trial court's obligation in giving a lesser?
Yes, Your Honor. I think this case has been pending for 3+ years. I don't have the exact math. I do not believe that the law is that the court must give a lesser if a lesser exists under the Ohio Revised Code. I think it is certainly, first of all, it's up to the judge to determine whether the evidence supports it. But it's not, we're afraid that we're going to lose as we've indicted, and so now we get a lesser. They've presented evidence and indicted a case on purpose with having to prove causation as well. That's the case that we prepped, that's the case that we've readied for, and as this court knows, and we've certainly litigated this issue, it wasn't until this newer set of prosecutors were on the case that we even received an email about their intention to ask for a lesser. Truly, that had never been discussed in the 2+ years, because had it been, we would have litigated the issue of immunity earlier. Also, Judge, you know best. You've been in this county for a very long time, and I've certainly done a lot of cases here. To say that this county does not indict on lessers is an inaccurate statement. They've had all this time to amend the indictment.
Okay.
We presented to a grand jury.
Judge, I've been here 24 years. Now, I know that is about probably half of what you've done, but we don't indict lessers. So I've done this job for 24 years. And with Jimmy and Ron, I did it for 23 of those years. So I am very much aware of how we indict. Any party can request a lesser if there's evidence of it. We're just asking for the opportunity to solicit that evidence from this witness, as we did with Dr. Ely, which is appropriate. The only reason we even talked about that lesser ahead of time was I was shocked by Ms. Menashe's assertion during a conversation we had, the one and only pretrial conversation we had about this in the summer, was that it was her assertion that because of the immunity statute, we would be barred from asking for any lessers, including reckless. She said, I understand that, but it's just the way the law is. And I was dumbfounded by her assertion during that conversation that there are no lessers in this case. I researched it, I had appeals research it, and they said, we don't know why you would not get a lesser in this case. And so I brought it up in the email ahead of time. Normally we don't discuss lessers until the close of evidence. And once again, it's both sides can ask. It's not like a defense thing. It's prosecutors can ask for lessers too, should the evidence warrant it. So I brought it up in an email because I thought it might be germane to voir dire and perhaps even opening. And so that's the only reason I brought it to the court's attention. So that's where we're at on it, Judge. We're at that point where we are asking permission to ask what we believe is a very relevant question, the defendant's state of mind. And it'd be the lesser state of mind. If it's not purposeful, is it at least reckless? Which I think is a perfectly acceptable question to ask this expert, as we did with Dr. Ely, who answered in the affirmative. Thank you.
Okay, well, just for the record, the simple asking still does not stop the court from going through the analysis they have to do.
Absolutely.
In order to put it there.
Right.
And the things I have, and that's what I'm basing my decision so far. I don't think it's relevant to this. I think everything is for the murder, and that's where we're at. So you made your record, we can go accordingly. The second issue, and I didn't really get a thing because we were kind of rushed, was about the leading questions. State of Ohio versus, and I'll spell it for you, D. Ambrosio, D''Ambrosio. Okay, 67, Ohio State 3rd, 185. Most of the questions haven't been leading. Even though they elicit a yes or no answer, it doesn't necessarily meet the suggestion aspect required there. I adopted for part of 611 C is that except as may be necessary to develop testimony, that's the usual transition between subject matters, summation, those types of things that are traditional things. I may have said transition. Most of the time they weren't leading questions, but I figured it was better for me to say I'll permit a transition so I didn't look like one side or the other was wasting objections. But that was the whole thing. We can go through the analysis as we go, but just a simple yes or no question does not make it leading. It has to be suggested into the answer. And saying, did you review the records? Yes, that is not a leading question. So I made my record there. Anything on the issue?
Not from the state. Thank you, Your Honor.
No, Your Honor.
Okay. Anything else for the good of the order?
No, Your Honor. Thank you.
Okay. We're on recess till 1:05. potential juror being on film. I just took a few minutes with the press to discuss issues with them. It's my understanding the juror was not actually on film. Okay, and I have not heard any reports that they were. I gave the suggestion they move it down the hallway so the possibility is eliminated. I explained to them the consequences of if another juror gets on film, that they will be removed from the courtroom. And I think I adequately represented. Any questions on the issue?
No, sir.
Any questions?
No, Your Honor.
You ready to go?
Yes, Your Honor.
Okay. Anything else to the record? No? Okay. All rise. I can bring back the results.
Thank you, please be seated.
Thank you, ladies and gentlemen. We have wonderful continuing testimony. Your doctor, you're still on the road. Ms. Brown.
Thank you, Your Honor. For the record, I'd like to turn back to the Beverly Scherzinger matter for a couple of quick questions. I'm going to present to the witness a page from the Beverly Scherzinger electronic medical record, page 156. Dr. Schweiker, would you please review that document? What is that document?
So this document is a procedure note, and it indicates the procedure of endotracheal intubation that occurred on October 9th of 2017 at 10:30 in the evening, and it lists the medications that were given, that 2 milligrams of Versed were given, and then the neuromuscular blocking agent succinylcholine, 200 milligrams, was also administered.
Thank you. Does that relate to the report for Mrs. Scherzinger wherein you previously discussed the existence or non-existence of this paralytic in the report?
Correct. I think there was an inaccurate entry regarding the cisatricurium, but in fact, earlier in the report, when I do discuss the intubation, it does indicate that succinylcholine, which is a neuromuscular blocker, was administered.
And how would that affect Ms. Scherzinger's person physically?
So succinylcholine is administered in order to paralyze the patient and allow the anesthesiologist or critical care medicine doctor to open the mouth more easily in order to place the breathing tube. In most patients, succinylcholine has a relatively short half-life. However, either due to genetic abnormalities or potentially due to underlying disease, one often has to be cautious that the effects of the succinylcholine have fully worn off before a decision is made to extubate the patient, because again, one would not want to extubate a patient that still has residual neuromuscular blockade on board, because that would prevent the patient from breathing.
And what was the time of this procedure and the administration of that paralytic agent?
So the procedure and the administration of the paralytic were at 10:30 in the evening on October the 9th. 50 minutes later, that was at 11:20 p.m.
Okay. I believe at this time, we want to transition to the hospitalization of Frances Burke. Ms. Burke is, her matter is reflected in count number 6. Dr. Schweiker, what was Ms. Burke's presenting problem?
So Ms. Burke presented with essentially an acute stroke, and it was determined that she had suffered a hemorrhage inside of the brain based upon the CAT scan. She had bleeding on the left side of her brain, and it was thought related to the fact that she had been placed on a blood thinner known as Xarelto, because earlier she had developed pulmonary embolism, clots going to her lung. So her doctors had put her on a blood thinner. But one of the known side effects is that if you have weak blood vessels in the brain or have chronic high blood pressure, it can result in a catastrophic hemorrhage. And that's what appeared to have occurred. Also, when she was admitted, around the area of the bleed, so not within the bleed itself, but almost as if you had a rim or a frame, she had significant vasogenic edema, which occurs from swelling around the brain.
Thank you. And I'm publishing at this point State's Exhibit 32H. Do you recognize this as your report in the Frances Burke matter?
Yes, ma'am.
And did you review the medical records in the Frances Burke matter?
Yes, I reviewed the entirety of her medical record that was provided to me.
Thank you. What was her hospital course?
So she was seen by pulmonary critical care, Dr. Closure, who did a comprehensive evaluation, and he discussed not only the acute change in her mental status that she had, but also the associated weakness on the right side of her body. And then he talked about the fact that when he saw her, she was completely unresponsive. And in fact, he actually recommended that they turn off the sedating medicine at that point to further evaluate her neurological status, because she had some abnormal posturing that often is seen in patients with severe brain injury. So that was done. Obviously, they stopped any further administration of blood thinners, and they were going to evaluate her condition moving forward to eventually determine whether or not she would get a brain death exam to see whether or not there was any neurological function.
Okay, and did that exam occur?
No, there was never an attempt at performing a brain death evaluation, which would have included both an apnea test to see whether or not she was over-breathing the set rate on the ventilator, as well as a detailed neurological exam to confirm the absence of both higher cortical and brainstem function.
In this matter, did the discussion move on to her DNR?
Yes, in fact, Dr. Closure had a discussion with the patient's husband, George, and several of the family members. First, because he wanted to explain to them that he had communicated with the neurosurgeons about whether it was feasible or not to operate on her to control the bleeding, and that neurosurgery did not feel that she was an appropriate surgical candidate. There was nothing for them to offer, and that he felt that even if she were to survive the acuity of this event, that she would have a very poor long-term neurological outcome.
Doctor, do you have an opinion about the survivability of Mrs. Burke?
Yes, based on the severity of the hemorrhage, as well as the neurogenic edema her survival would be estimated to be less than 5%. So it was not zero. There was a chance that as the edema resolved and the bleeding resolved, that she could come out of the coma, but she would certainly have had significant residual neurological deficits, particularly on the opposite side of the body of the hemorrhage. Since she had already presented with right-sided weakness, it's very likely that she would have been permanently paralyzed on that side of her body.
Did you review materials pertinent to her matter about her affect and pain or level of sedation?
I did, yes. I reviewed the pain scores and the sedation score, as well as the Glasgow Coma Scale.
What did that review reveal?
My review of those documents indicated that at the time that she was admitted and throughout that she was essentially in a coma, which is not surprising given the bleed and the edema in the brain, and that it did not appear that she had significant pain.
Thank you. Do you have an opinion in this case about whether or not her course could have, or strike that. Do you have an opinion in this case about whether or not it would have been advisable to continue to pursue her medical options?
Yes, I do have an opinion.
What is that opinion?
So I agree with Dr. Closer's assessment that it was reasonable to make her DNR CCA so that if she actually experienced cardiac arrest during the hospitalization, that she wouldn't be resuscitated. But given that this was an acute event, meaning that she had bled secondarily to the medication, and that she had significant edema around the area of the bleed, it would require a period of time, again, as I would estimate, 72 to 96 hours to definitively tell her husband that she was non-salvageable and not survivable, because one can be significantly surprised in these type of patients. Early in the phase of the intracranial hemorrhage, they can appear completely obtunded and that they're not going to survive. But once the swelling and edema go away, you can certainly have patients, as I said, probably a 5% chance of survivability. And if the family and the spouse are willing to accept the inherent limitations of that patient, that they would have some residual paralysis, then it certainly is reasonable to continue supportive care until the patient themselves declares that they're not salvageable.
And what happened in this case, however?
So again, in this case, Dr. Closer did appropriately discuss the change in the DNR status that was going to be placed, because he was also concerned that swelling could lead to brainstem herniation. That's when pressure in the brain can push the brain downwards and push the lower part of the brain through the base of the skull, which is a medical catastrophe. If that occurs, you can't survive that without immediate surgery. So then at that point, there was a call, and remember, he had made her DNR comfort care in an arrest, but then there was a note that was entered that day, January 14th, from Dr. Hussel, indicating that in a discussion with the family members, it was decided to change her status to DNR CC, meaning that she would be made comfort care and that there would be progression to withdrawal of care after excavation.
Thank you. Have you reviewed the pain scores in this matter?
I have, yes.
I will be approaching the witness with Francis Burke's pain score page, which is found at page 123 of the medical record.
I've reviewed it.
Thank you. What does the record with regard to her pain scoring reveal?
So her medical record indicates from the time that she was admitted to Mount Carmel West on January 13th up through the decision for the terminal extubation, she was described on the COP score as having 0 pain. There was no indication. It was consistently 0, 0, 0, 0, 0, and that the nurse assessed her pain control as acceptable, yes. So again, as one would expect in this situation, she was not reporting any pain. And then at the last entry, there was a pain score of 10, but that correlated around the time that she was being given the medication for the terminal extubation.
Do we know what time the medication was administered for the extubation?
Yes, the medication was administered around 12:02 a.m., and that was 1,000 micrograms of fentanyl.
Thank you. Was 1,000 micrograms of fentanyl an appropriate dose in advance of removing ventilation in this lady's care?
In my professional opinion, given that she had a recent brain hemorrhage, as well as the significant vasogenic edema, the administration of 1,000 micrograms of fentanyl was not medically justified, particularly given that throughout the 13th and the 14th, there was no indication of any pain, let alone significant pain. And given the fact she had bleeding and swelling in the brain, it is unlikely that she would have been able at that point to perceive pain. So again, had the brain healed, perhaps later on, that could have returned if she was one of the lucky survivors. But certainly at the point the terminal extubation was made, there does not appear to be any medical justification for administering 1,000 micrograms of fentanyl.
What purpose could this dosing serve at this level?
Well, it would not have any medically justifiable purpose because the only purpose would be to treat pain, and she did not appear to have any. So thus one is led to believe that the decision to administer 1,000 micrograms of fentanyl would be in order to depress her respiratory status, because even with the bleed in the brain, it would penetrate the brainstem and it would make it impossible for her to maintain spontaneous respiration. And with the loss of spontaneous respiration, not only would her oxygen drop, but the carbon dioxide would go up, and that would cause the brain to rapidly swell further and thus cause fatal herniation by causing the brain to press downwards and would rapidly result in the patient's death.
In your practice and experience, what would be an appropriate dose for extubation in Mrs. Burke's case?
In my experience in personal practice, had fentanyl been chosen as the medication to administer, a dose of 50 micrograms to 100 micrograms would have been adequate, with, of course, standing orders to administer additional small doses if, in fact, the patient showed any signs of pain or distress once the breathing tube was removed.
Thank you. In your opinion, did the dosing of 1,000 micrograms of fentanyl hasten and or cause her death?
Yes, in my professional opinion, the administration of 1,000 micrograms of fentanyl, given the underlying brain injury and swelling she had, certainly did hasten the patient's death following the extubation and withdrawal of support.
In your opinion, does the doctrine of double effect have any application in this case?
No, in this particular case, having reviewed the medical record, the doctrine of double effect does not apply because this was a patient with a very tenuous brain exam. Clearly, it was known she had blood in the brain. That was acute. She also had swelling in the brain. So the doctrine of double effect would argue for moderation proportion, which would be not to give pain medicine in a patient who does not experience pain, and knowing that any drop in oxygen, but equally important, any rise in carbon dioxide would cause the brain much more rapidly to swell and lead to fatal transtentorial herniation through the brainstem. And given that neurosurgery had already opined she was not a candidate for any neurosurgery, it would be a fatal event. So I do not believe the doctrine of double effect can be applied in this case.
Thank you. What actions or lack of action taken by Dr. Hussel speak to his intent in this action, in this matter?
So first, the lack of allowing time for Miss Burke's brain swelling and brain edema to declare itself, at least to give her an adequate period of time of 24 to 48 hours to see whether or not the level of swelling or bleeding within the brain would level off and allow for a follow-up CAT scan to assess the brain. Also, as was initially planned, to proceed the next day with a more comprehensive neurological examination, and if need be, to actually perform a brain death exam to see whether or not there was activity at the brainstem that would have indicated a prognosis and allowed for a more comprehensive discussion with the patient's spouse and the family. And then also to convene palliative care, to convene Dr. Closure, who had performed a very detailed assessment of Ms. Burke upon admission. He has a very detailed note in the record, would all be steps that would be indicated before a decision for terminal extubation and withdrawal of support.
Thank you, Doctor. I'd like to turn now to the medical records and matter involving Jer Amy Hodge. Jer Amy is also known as Sue Hodge. It's a little easier to remember. Did you review Mrs. Hodge's medical records, Doctor?
Yes, I did review the entirety of Ms. Hodge's medical record.
Thank you. And did you prepare a report?
Yes, I did prepare a report after my review of her medical records.
Thank you. What was, did she present to Mount Carmel West?
Yes, Ms. Hodge was transported to Mount Carmel West by EMS after she had an out-of-hospital cardiac arrest. Ms. Hodge did have a prior history of underlying coronary artery disease. Approximately a year before this event in April of 2018, she had been taken to the cardiac catheterization laboratory, and she had had stents placed inside her heart in order to open up blood flow. So she was known to have a cardiac history. She had abnormal lipids and cholesterol. She had underlying diabetes. She had hypertension. And this case was described as what's known as a witnessed cardiac arrest, because she had actually been on her way to walk to her car and then to drive. She was planning to drive herself to the emergency room to seek help when she collapsed. So the personnel or the people that were there immediately started CPR while EMS was called to resuscitate her.
Thank you. And who did resuscitate her?
So EMS had to resuscitate her. When they got to the scene, her heart was not beating. So they not only did basic life support, taking over the CPR by the bystanders, but they immediately transitioned into advanced cardiac life support. They gave her 2 doses of adrenaline to restart the heart. And at that point, she did not immediately respond. So they gave additional doses of adrenaline and then gave a powerful anti-arrhythmic of the heart known as amiodarone to help the electrical circuit of the heart. And eventually they regained a pulse.
Thank you. What was her hospital course?
So her hospital course was consistent with that, what you would expect of somebody that had a major cardiac event outside the hospital with prolonged resuscitation. First of all, she was worked up extensively from the heart condition, and it was felt that she had what's known as an inferior wall ST segment elevated myocardial infarction. So essentially, the bottom part of the heart that's fed with the blood did not get enough blood, and that caused her heart instability and essentially caused the heart attack. Because she had been down in the field and required EMS and the bystanders to have a long CPR, her blood was very acidotic. I believe when she first was drawn, it was 6.73. So that showed that she needed resuscitation of that acid-base status. And so they basically, at the point that she was admitted, Dr. Fahl, P-F-A-H-L, who was the cardiologist, had been called for what's known as a STEMI alert, which means that they take them immediately within 30 minutes to the cardiac cath lab to see whether or not any of her prior stents had clotted off and would need to be opened. And he then did a comprehensive cardiac catheterization, and it actually showed that the stent that had been placed a year before was open, and that although she had some other disease in her vessels, he did not feel that any of these vessels was the culprit of the arrest, but rather he thought that there might be some contribution of what Dr. Fahl described as a non-cardiogenic arrest, that something else had pushed her over. So he actually recommended that the very next day that they would do echo imaging, where they shoot ultrasound beams on the chest to see how the heart's contracting. And he actually put in his note, he didn't at that point need further cardiac testing on that particular day.
Did you place that note in your report for Ms. Hodge?
Yes, it's on the top of page 3.
Oh, okay. Suspect she had non-cardiac arrest, reasonable for echo tomorrow.
Correct. And he also, as I put there, he noted that her EKG, although it did have changes, was much more likely caused by the acidosis, the change in her pH and electrolytes, than the primary heart dysfunction itself.
Thank you. What happened next?
So a critical care consult was placed to evaluate her in the ICU and to determine the plan. And that consultation then appeared to go to Dr. Hussel, but I could not find a comprehensive or detailed critical care assessment that would have included history, physical exam, differential diagnosis, assessment, and plan. Rather, there appeared to be on page 15 of the chart what was described as a death note that essentially described the decision to transfer her to DNR comfort care measures, because after she returned to the ICU, she had experienced another arrest. And this does sometimes occur. When the heart is irritable, you can have a series of arrests. But again, given the findings in the cardiac cath lab, there still appeared hope, since it wasn't a primary heart issue, that had supportive care been given, that she may still have come out of this situation with correction of the underlying electrolyte abnormalities.
Was she intubated?
I believe as part of the initial resuscitation, she was in fact intubated, yes.
Okay. And then did you review Glasgow pain or RAS scores?
Yes, as a review of the medical record, I looked at the pain scores that were included. I looked at the Glasgow scores, and I looked at any type of other documentation of her mental status by the nurses.
What did she score out at?
Essentially, she did not have any indication of pain. Her pain score was attributable to a 0.
Thank you. Did there arrive a time where extubation occurred?
Yes, that evening of April the 1st, 2018, as indicated by the note, there was a return of spontaneous circulation in the ICU after 6 minutes of CPR. And then the decision was made to transition Ms. Hodge to DNR comfort care, after which there was then a decision made for terminal extubation. The patient was administered 800 micrograms of fentanyl and also received 6 milligrams of Versed, and then the patient expired thereafter.
Thank you. Was the palliative extubation appropriate?
In my professional opinion, based on the sequence of events and that note from the cardiologist who actually had performed the cardiac catheterization, and given that there were ongoing acid-base disturbances that needed to be corrected, it was too soon to make a decision to transition the patient based upon complete terminal status or futile care. Certainly, I would agree she was very, very sick. She had undergone, the prolonged initial resuscitation and the subsequent one. But given that she was still relatively young and had this essentially unremarkable cardiac catheterization, an ample period of time should have been allowed to allow the patient's condition to reveal itself as to whether or not her heart and the rest of her body could have stabilized itself with the additional medical support before a decision for terminal extubation was undertaken.
How would you undertake such a period of observation?
So clearly, this patient justified admission in the ICU. The patient obviously needed continuation of having the breathing tube in place in order to continue mechanical ventilation to help blow off carbon dioxide and give her oxygen. Also, given her status at the time, it's very likely she would have needed vasopressors and heart medication to stabilize her. The administration of alkalinizing agents, particularly sodium bicarbonate, which is injected intravenously, and if need be, a brief trial of continuous dialysis would have at least answered the question as to whether or not the electrolyte abnormalities and the acid was the cause of her heart dysfunction or failure. And of course, if after a day or two that had proved unsuccessful, at that point then, yes, by including cardiology, by including palliative care, would have been reasonable to discuss end of life. But certainly this was relatively quick, and particularly given that they had not even done a follow-up echo as recommended by the cardiologist, it did not seem appropriate at that time.
Thank you. Have you reviewed the dosing that was administered to this patient pursuant to the extubation?
Yes, I did review the dosing.
What was the dosing?
So the dosing was 800 micrograms of fentanyl given in combination with 6 milligrams of Versed.
Is there any legitimate medical reason for this dose of fentanyl and Versed?
No, having reviewed her chart and noted that her pain score was essentially a 0. Also, given that at that time her Glasgow Coma scale was a 3T, meaning she was intubated and she was not showing response to the physical examination. And I believe her pain scale was also at approximately 920, scored as a 2, which would have been a -2 for her. There did not appear to be any reasonable justification to administer 800 micrograms of fentanyl, nor did I see any justifiable medical reason to administer Versed along with the fentanyl, since at that period of time, there did not appear to be any undue fear, anxiety demonstrated by the patient.
What purpose could this dosing serve at this level?
Certainly, there was no therapeutic purpose to administering the high-dose fentanyl or Versed, given that she wasn't showing really clinical signs that she would benefit from the fentanyl or Versed. The only logical conclusion from that administration was an attempt to suppress spontaneous respiration, which, given that she had had the multiple cardiac arrests, would result in a significant depression of her ability to breathe and thus worsen the acidosis in her blood, which would eventually cause her heart to stop for a final time, which would culminate in her death.
In your opinion, did the dosing of 800 micrograms of fentanyl plus the midazolam hasten and/or cause her death?
Yes, more likely than not, within a reasonable degree of medical certainty, the administration of the 800 mics of fentanyl in combination with the 6 milligrams of Versed did hasten and cause or contribute to Mrs. Hodge's ultimate death.
In your opinion, does the doctrine of double effect have application in this case?
In my opinion, the doctrine of double effect is not justified because it does, again, the administration of these medications without any documented significant pain or anxiety does not show either moderation or proportionality, and there's tremendous risk in giving these because it would depress her ability to breathe, and given her severe acidosis, would strongly result in the possibility of her rapid death.
What actions or lack of action by Dr. Hussel speak to his intent in this matter?
So first of all, the ordering of the fentanyl and the Versed at these dosing speaks to the underlying intent of the action. Number two, the failure to follow the recommendation of the cardiologist who had performed the stimulus and done the cardiac catheterization. Dr. Fail did not appear, based on the medical record, to have been involved in any group discussion about proceeding to terminal extubation or withdrawal of support of the patient. The failure to obtain the recommended test on the subsequent day also would point towards the intention for the hastening of the death. And then the failure to correct the underlying acid-base disturbances, which was the working diagnosis of the cause of her cardiac arrest. Since, again, Dr. Fail did not find an acute blockage in the heart vessels at the time he performed the cardiac catheterization. One would have to continue to investigate and look for the cause before concluding that this was truly a terminal event.
Thank you. I'd now like to turn to the matter involving James Allen. Doctor, did you review the medical records in this matter and prepare a report?
Yes, I reviewed the totality of Mr. Allen's medical records, which spanned approximately 5 days at Mount Carmel West, and I subsequently prepared a written report.
Thank you. What was Mr. Allen's presenting problem?
So Mr. Allen's presenting problem was relatively vague. It was progressive lethargy. Mr. Allen had underlying multiple medical problems. He had a history, as is demonstrated here, of ischemic cardiomyopathy. That means heart failure related to blockage of the arteries, and the ejection fraction was estimated to be only 10 to 20%. He also had type 2 diabetes and required insulin. He had primary high blood pressure, which is essential hypertension. He had bad reflux disease. He had atrial fibrillation, which is an irregular heartbeat. He had known coronary artery disease. His heart had ballooned out in size, so that's the dilation of the cardiomyopathy. He had had a pacemaker placed. He also was a heavy smoker for many, many years, and he had developed COPD or emphysema. And the concern was that he had some process going on in his abdomen. Ultimately, it was found that he had significant sludge and stones essentially in the bile ducts itself. And so there was inflammation and suspected infection in that area because of the blockage. So he underwent, as was demonstrated here in the history of present illness, a procedure known as ERCP, in which the stomach doctor, the gastroenterologist, puts a scope through the mouth, down the esophagus, through the stomach, and then is able to look in the different pathways, the one for the bile duct, the one for the pancreas, and they were able to extract some of the stones, the sludge, and then the word abscess is there. An abscess is a walled-off infection, so it's essentially a pus pocket. And that was what was basically the primary reason. And then it also described that he had started to turn yellow, meaning jaundice, which occurs when the liver or the bile duct is blocked.
Thank you. And what was the length of his hospital course?
He was hospitalized for 5 days from May 24th through May 28th.
Thank you. Was he directly admitted to the ICU?
He was not directly, I believe he was not directly admitted to the ICU. What happened was he initially went through the GI workup, the cardiology workup, and then what occurred was on May 28th, so several days into the hospitalization, he had an exacerbation of the atrial fibrillation, which was the irregular heartbeat. And as a result of that, and I take it back, I think he was transferred out of the ICU, and then when he went to the med-surg floor, he developed the atrial fibrillation as he had been weaned off the vasopressors, and then he had to return into the ICU because of low blood pressure.
Okay, and then what happened?
When he got back to the ICU and he was seen by Dr. Adam Mahoney, who's one of the critical care doctors at Mount Carmel West, it was discovered that he had significant coffee ground emesis coming up. So basically he was vomiting up material that looked like coffee grounds. This usually means that there's some form of either gastritis, inflammation of the stomach lining, or some gastrointestinal bleeding. So he was brought back and he had to be intubated at that point because he went into pulseless electrical activity and suffered a code blue. So as a result of that and the underlying diagnosis of shock, he was successfully resuscitated and he was started on the vasopressor support, as well as broad spectrum antibiotics because of the abscess they had found in the portal system.
Thank you. Did he have any invasive procedures?
Yes, well, he had, by definition, the ERCP is invasive because it requires the doctors to put a scope down his throat and to look into the stomach, the bile ducts and what have you. So he had that. Obviously, he had the endotracheal intubation that occurred. So there were invasive procedures done.
Thank you. Did you review the pain charting for Mr. Allen?
I did, yes, ma'am.
Mr. Allen's pain scores, for the record, appear at 556 to 558. I'm going to ask you to review these. Refresh your recollection. What can you deduce from the pain scores?
From the time of his admission, the documentation of the pain score was essentially at 0, and the nurse described the level of his pain as acceptable, since again, he wasn't documenting or demonstrating any pain until there was a documentation of some pain during the final process of death.
I'm placing the exhibit on for publishing, showing the last days, top of the day of the 27th, or the bottom of the day of the 27th, and all of the pain scores on the 28th. What do you see on there?
So what I see is starting at 8 p.m. or 2000 hours, there was either no pain score given by the nurse, or then on May 28th at 9:50, there was a 0. The only indication of pain was that of Gabriella Thompson, who 5 minutes after noon did score him as a 5, but then it immediately went back to 0 and remained 0 up until the last entry at essentially 8:47 that evening.
Thank you. Doctor, was there a discussion about his code status?
Yes, there was a discussion, I believe I addressed it on page 15, about the code status. This was documented by Dr. Jennifer Weiss. And she had a discussion, first of all, on the phone with the patient's spouse, the wife, Barbara, in which the spouse had essentially relinquished the healthcare power of attorney to Mr. Allen's son, because he had some experience working as an EMT, and it was documented that the wife felt that the son and the children would be in a more appropriate position to be the power of attorney. And it was documented both by Dr. Weiss and Dr. Gandhi at the time of this entry that the children wanted him to be essentially a full resuscitation. And that then there was in fact an entry that was entered into the electronic medical record of that, as well as the order that had initially been placed and confirming on May 24th that the patient was full resuscitation.
What happened then with respect to his code status?
So on the 28th, there had been an observation that the blood flow to Mr. Allen's left foot had become absent. And so a consult was placed to vascular surgery to evaluate the status of that left foot and see if anything could be done. That occurred at around 8:35 in the evening. But before that consult could even be completed, there was a change in the DNR status at around 11:14, where Dr. Hussel changed him from full resuscitation to DNR comfort care.
Then what happened?
At that point, then there was an order placed for 1,000 micrograms of fentanyl and an order for 6 milligrams of Versed to be given to the patient. And I saw thereafter a death note that indicated that the patient had expired and was asystolic, and the time of death was 11:40 p.m.
Thank you. Do you believe that the dosing pre-extubation in this matter was appropriate?
In my professional opinion, the dosing of 1,000 micrograms of fentanyl was inappropriate for Mr. Allen, given the fact that he had only one documented report of pain, and it was controlled easily without such excessive doses. And at the time that the administration was being given, the order had been placed for a vascular surgery consult to assess his foot. So it didn't appear to be reasonable to administer 1,000 micrograms of fentanyl, nor to add to it the Versed of 6 milligrams.
In your opinion, was there some chance for salvaging Mr. Allen?
Yes, certainly Mr. Allen had complex medical issues. Many of them were chronic, and one certainly would include that in the discussion with the family so they could understand that. But as was demonstrated by his workup, he clearly had a defined cause of the deterioration, meaning he had the stone, the sludge, and the abscess that was identified. And again, when you have pus pockets in the body, it can take not only days, but weeks of antibiotic administration and also possible subsequent redrainage to completely clear that. So it again seemed hasty based upon the course that he was following. Also, the experience of the coffee ground emesis after the procedure and the fact that there was concern about potential bleeding or aspiration, those are also items that can be addressed by critical care. So there did not appear to be any rush to proceed to terminal extubation or withdrawal of care, given the fact that at least up to just prior to that, the son who had been the power attorney had wanted full resuscitation measures and at least to give his father a period of time to declare himself whether or not he could overcome this and return to his baseline status, albeit that did include chronic medical conditions.
What purpose could this level of dosing serve?
Certainly in Mr. Allen's case, there's no clear indication of any therapeutic benefit, given that he wasn't experiencing any form of significant pain that wasn't controlled with just conservative measures. And similarly, that there was no documentation of excessive anxiety or agitation. The only conclusion that I could draw on reviewing the records that the administration of the 1,000 micrograms of fentanyl in combination with the Versed at around the time of the terminal extubation was to depress his respiratory status to the point where he would rapidly breathe inefficiently or cease to breathe and develop apnea, which of course would then result in an untimely death of the patient.
In your opinion, did the dosing of the fentanyl and Versed hasten and/or cause his death?
Yes, within a reasonable degree of medical certainty, the administration of the 1,000 mics of fentanyl in combination with the 6 milligrams of Versed at the time the endotracheal tube was removed did in fact hasten Mr. Allen's death and thus prevent a natural death that would have otherwise occurred had these medications not been administered at these doses.
In your opinion, does the doctrine of double effect have application in this case?
In my professional opinion, this case does not support the doctrine of double effect, given the fact that he had a known diagnosis, was undergoing active treatment for that diagnosis. In this particular case, he was not demonstrating unusual or abnormal pain or pain that could not be controlled with conservative measures. And given not only the change in healthcare surrogacy that had been recently changed to the son, but also the express desires of the family to continue with care until the patient's condition declared itself, I don't believe that this case demonstrates either moderation or a proportional response, specifically given that neither the fentanyl nor the Versed had any therapeutic benefit to Mr. Allen.
What actions or lack of action by Dr. Hussell speak to his intent in this matter?
So certainly the lack of communication with the treating physicians, in this case, certainly the major issues were of the gastrointestinal tract, and to discuss with the GI team what in fact was the prognosis of this infection and the cholangitis that had been diagnosed. Also, the failure to wait for the vascular surgery consult to see whether or not there could be any conservative measures employed to reestablish blood flow to the lower extremity. And then the failure to incorporate discussions with palliative care or to place an appropriate consult for palliative care, particularly given the patient's status and also the fact that his wife also was elderly and had health issues and the son had taken over. Those all would be appropriate steps at that point. And then to write a definitive note justifying what the deterioration was in Mr. Allen's case that would necessitate a rapid progression to a terminal extubation in the middle of the night when the plan had already been laid out for further continuation of supportive care in the ICU.
Thank you, Doctor. I'd like to now turn to the case of Troy Allison. Have you reviewed the medical records in this matter?
Yes, I have reviewed the medical records of Troy Allison.
Thank you. When was this gentleman admitted to the hospital?
So Mr. Allen was admitted on July 15th of 2018.
And what was his admitting diagnosis?
His admitting diagnosis appeared to be cardiac arrest in the emergency room.
Do we know why he went to the emergency room?
Yes, in terms of his presenting symptomatology, Mr. Allison, he was 44 at the time. He had a chronic ulcer of his right lower extremity. He had very poorly controlled type 2 diabetes, and he had hypertension. He had sought help in the emergency room due to difficulty breathing. And then when he arrived, he was found to have very poorly controlled blood sugar, so significant elevation, and also underlying acid-base disturbances. And then, as mentioned, he rapidly progressed to a code blue situation. And subsequent to that, there was concern about acute lung injury and adult respiratory distress.
I've got your, I have States Exhibit 32K, your report in this matter, up on the projector. And there's a discussion in there about a 1 to 2 minute generalized tonic-clonic seizure. What is that?
So a tonic-clonic seizure is when the patient has irregular muscle movements that would mimic what one would experience if someone had epilepsy. The arms and the legs are involuntarily contracting. Now, again, unlike in epilepsy where there can be irregular firing within the brain, in Mr. Allen's case, it was likely due to alterations in his cardiac and respiratory status that resulted in the disinhibition. You can often see that at around the time that a patient is either going into or coming out of a cardiac arrest, which is the period of time that this was occurring.
Okay. What happened after the emergency room and the code?
So after, obviously, the code, he was intubated and effectively resuscitated. He was a large man, and he had abnormal arterial blood gases. His pH was documented to be very acidotic. I saw one that was 6.53. He also had electrolyte abnormalities, meaning he had a low sodium. His chloride was low. His anion gap was markedly elevated. And most importantly, his blood sugar was 875. So it was very, very high. He was supported on the mechanical ventilator, and consultation was placed in the chart for critical care consultation. But again, I could not find a comprehensive critical care evaluation that would have gone through an assessment of his presentation, his physical exam, the laboratories, a differential diagnosis or assessment plan.
Thank you. Do we have a list of his home medications?
Yes, I believe I placed on page 3 a documentation of what was included regarding his home medications, which included the insulin pens that he was prescribed, a glucometer, the Novolog, and then also he had been managed with what looked like extended release morphine, so outpatient management of pain. He was also on the antidepressant nortriptyline, which can also be used for patients that have chronic diabetic pain. As one of the side effects of the drug, it can be beneficial there. He was also maintained on pantoprazole, which is to reduce stomach acid. And then he was receiving gabapentin, which is also known as Neurontin. It's primarily used for pain control, but was invented as an anti-seizure medication. So that's often used for patients that have atypical pain. as an adjunct to other pain modalities. And then he was receiving an oral medication for his diabetes known as metformin. And then he was on a beta blocker for both heart rate and blood pressure control called metoprolol.
Thank you. Were there pain scores noted for him?
Yes, in review of the chart, even though it was a brief admission, I did see pain scores included in his medical record.
And what were they?
May I have the sheet to just
Sure.
confirm them?
Yeah, I have it. Did I take it out?
Actually, I take that back. I don't believe in looking at my report that he had any documented pain scores in this case. So I misspoke.
Thank you. That explains why I'm not finding it. Okay. So, Doctor, given his situation as presented, do you feel, or is it your opinion that Mr. Allison had some hope or some salvageability medically?
Yes, it's clear that Mr. Allen was very ill for his age. Being 44, unfortunately, he had a host of problems attributable mostly to his weight and his diabetes. But certainly, given the acuity of the deterioration and the correspondence with the potential of this poorly healing ulcer, which speaks to septic shock and potential sepsis, again, a reasonable period of observation would have been prudent to assess whether or not he would have stabilized, particularly given that he had significant acid-base disturbances and he had had such a rapid deterioration following the admission to the ICU. Also, the presence of the question about his lung issues, the acute lung injury and ARDS, would have needed more investigation to determine the severity of those in terms of prognosticating his ultimate demise.
What treatments would be appropriate for this patient if he were going to undergo the period of observation?
Well, first of all, the most important cornerstone for Mr. Allison would have been to get his blood sugars under control by use of insulin drip or infusion to normalize the blood sugar in the range of 100 to 150. Again, he obviously had such high blood sugars that presents and can itself cause what's known as diabetic ketoacidosis, where you become so acidotic from the high blood sugar because you're also so dehydrated, because the sugar actually will go out of the kidney and bring water with it. And he had reported when he first arrived that he had experienced several days of extreme thirst. So this appeared to be consistent with a presentation of diabetic ketoacidosis. Also, of course, while one is doing that, volume expansion, because these patients can be more than a gallon or more, sometimes 2 gallons, deficient in water in the body. So one needs to slowly reconstitute that to make sure that the water has ample time to equilibrate both in the cells and tissues of the body before one can definitively determine that there's no salvageability of the patient. And then again, given that there was concerns about the lung, doing some essential basic lung testing to see whether or not the lung itself really was progressing to adult respiratory distress syndrome. Also, given the fact he had an unexplained cardiac arrest, obtaining the echocardiogram of his heart to see how well the heart was contracting, all would have been necessary before the next phase, which would have been first to stabilize him and then decide, and also rule in or rule out any wide infection in his blood. Because again, certainly at that point, he was not stable to take to the cardiac catheterization lab. But if in fact they could have controlled and stabilized him, then he would have warranted a cardiac catheterization to see what the blood vessels look like in and around his heart.
Thank you, doctor. At some point, was there a discussion about his DNR
Yes,
status?
that evening, there was a discussion about the DNR status, and I saw an entry into the chart, which essentially, I believe here, let me just confirm that. So initially, I saw that there was an order for full resuscitation measures, and then, I guess, later that night, there was an entry. Actually, I don't see in my note the entry about DNR.
Okay. Irrespective of whether one was a parent or not, did this gentleman move on to a palliative extubation?
He did, yes, ma'am.
Okay. And what medication was offered or administered in conjunction with the extubation?
In Mr. Allison's case, he was ordered 1,000 micrograms of fentanyl to be administered to the patient intravenously.
Thank you. Does the fact that this gentleman had home medications of the gabapentin and the morphine inform your opinion as far as the proper level of dosage for a palliative extubation?
So one would have to take into consideration whether there was any tolerance to the medications in determining the dosing schedule. But in reviewing Mr. Allison's medical records, while he was at Mount Carmel West, there was no indication based on his condition that he had obvious tolerance to the medications. So the major focus would be to investigate the impact of his morphine usage as an outpatient. Again, no detailed assessment was made other than that there had been a prescription placed for the morphine. The gabapentin would be unlikely to impact the actual dosing of the fentanyl moving forward. So again, based on what was evident in the medical record, it would appear that judicious incremental fractionated dosing would be the most prudent should a terminal extubation and palliative withdrawal be considered, rather than immediately concluding that a very high dose of fentanyl needed to be given.
What purpose could this dosing level serve, the dose that was administered?
In my professional opinion, there was no medical justification for the administration of 1,000 micrograms to Mr. Allison, given all that was known about his medical condition, his rapid deterioration in the emergency room, the subsequent events in the hospitalization, the known acid-base disturbances, what appeared to be some dysfunction of the liver and the kidney, even with the consideration that he had been prescribed pain medicines as an outpatient, the absence of any documented pain scores in the chart or any other documented indication of him being uncomfortable would preclude ordering such a high dose.
Thank you. In your opinion, did the dosing of the fentanyl and Versed, or no, I'm sorry, in this case, no Versed, the dosing of the 1,000 micrograms of fentanyl hasten and or cause his death?
Yes, in my opinion, within a reasonable degree of medical certainty, the administration of 1,000 micrograms of fentanyl, as indicated at approximately 1:25 on July 15th, did in fact hasten or accelerate the patient's demise, as the time of death appeared to occur only 3 minutes after the administration of the fentanyl to the patient and the terminal extubation.
In your opinion, does the doctrine of double effect have application in this case?
No, in my opinion, this case does not support the application of the doctrine of double effect, given that there was no attempt at moderation. There was, as mentioned, there was no indication based on pain scores or other objective evidence in the medical record that Mr. Allison was suffering, or that he had significant tolerance to the opiate that he was taking, the morphine, or the additional gabapentin that had been prescribed. And he had significant underlying acid-base disturbances. So the doctrine of proportionality, which is part of the doctrine of double effect, again, is not justified in this condition.
Thank you. What actions or lack of action taken by Dr. Husel speak to his intent in this matter?
So in terms of the lack of actions, the lack of attempting to aggressively resuscitate Mr. Allison from the obvious diagnosis of diabetic ketoacidosis, the severe underlying systemic change in his pH, as well as the markedly elevated high blood sugars, were certainly inappropriate in terms of deciding whether or not this patient's condition was terminal. Also understanding and doing further workup of his heart and his lungs to see what reserve capacity Mr. Allison had before making a conclusion that this was a terminal case, points to the intention of, in this particular case. And then the lack of moderation in dosing, as well as the lack of proportionality, also speaks to the intent in this case.
Thank you, Doctor. Doctor, I'd now like to turn to the matter involving Bonnie Austin.
Before we start this, how you guys holding up? Y'all good? I'm getting mixed reviews here. Let's keep on working then.
I'm holding up Bonnie Austin's medical record, which is State's Exhibit 10. Did you review Bonnie Austin's medical record?
Yes, in preparing my written report, I reviewed carefully Ms. Bonnie Austin's medical record.
And when did she present to Mount Carmel West?
Ms. Austin presented to Mount Carmel West on September the 30th of 2018.
And what was her presenting problem?
Ms. Austin had presented in a essentially code blue situation requiring ongoing resuscitation by the EMS team, who had initially been called to her residence because the patient had been struggling to breathe, and they had found the patient alert and oriented, sitting in a recliner, self-administering, meaning she was giving herself a breathing treatment because she had underlying lung problems. And unfortunately, as a result of then a deterioration, the patient suffered a cardiac arrest, but was immediately then attended to by EMS with high quality CPR. And they placed what's known as a Lucas device, which is essentially an automatic device that does the compressions on the backboard. So rather than the EMS or physician having to do CPR, the Lucas device was activated. And they secured her airway by placing an endotracheal tube in the patient. And they documented that they had adequate carbon dioxide coming out during the resuscitation, which speaks to the efficiency of the CPR that was undergoing. She was getting good blood flow, not only to the heart, but to the remainder of her body. And then once she arrived in the emergency room, the ER staff was suspicious based on the fact she started with the breathing problem, that there might be an abnormality in her lung that caused her cardiac arrest. So they obtained a chest x-ray, and in fact, what they immediately identified was that she had what's known as a pneumothorax, that one of her lungs had deflated. In many people with emphysema, they get blebs in the lung, kind of an outpouching. It's a thinning of the lung. And if that ruptures, the lung will collapse and they can then not ventilate, which made sense given her shortness of breath and that she was also giving herself a breathing treatment. And so from there, then they asked the surgical resident, I believe Dr. Hussel, to place a chest tube into the chest wall, which then evacuated the air and allowed her lung to reinflate. And with that, then her heart function returned.
Do you know whether or not she was given pain medication when the chest tube was inserted?
I believe she received topical numbing medicine, which is the standard when we do that, but I would have to look at the MARS to see whether or not she received any intravenous medication. Routinely, if the patient is suffering an arrest, we wouldn't give intravenous medications for the chest tube during the arrest.
Bonnie Austin's MARS is page 106.
Thank you. So the medical administration record indicates that one dose of fentanyl was administered at 23:23, which is 11:23 p.m., but that was at the request of Dr. Hussel. And then the subsequent medications were related to the terminal extubation. On this sheet, I do not see any indication that Dr. Hussel or the emergency room doctors administered intravenous pain medications during the insertion of the chest tube.
Thank you. Did you review any pain scoring for Ms. Austin?
Ms. Austin had a very thin chart. She was only at Mount Carmel for a very short period of time. I believe that there may have only been one indication of pain score, and that was a 0. And then she obviously remained comatose during the period she was there. So her Glasgow coma scale would have been a 3T, the T being for the intubation, that there's a tube in her mouth. So that was really the only thing that I appreciated.
Do you have an opinion as to what her prognosis would have been upon leaving the emergency department?
So Miss Bonnie Austin falls into that category of patient that has an unpredictable prognosis. And why I say that is because her presenting rhythm was pulseless electrical activity, or PEA. So what that means is that the reason that her heart stopped was not primarily her heart, but as I testified to a little earlier, the reason she developed PEA is because she experienced the deflation of her lung. So in those patients, it's very important to give a period of time for the patient to declare themselves, because as long as the patient receives high quality CPR immediately, which she did receive, she also received high quality CPR from the Lucas device, and this was confirmed with the capnography, so there was objective testing. That indicates that during the resuscitation, there would have been adequate blood flow going to her brain. Also, the fact that they had decompressed and the pneumothorax by putting the chest tube in and allowed the lung to inflate. These are patients who can regain consciousness and they can participate in self-determination as to what they want for the remainder of their hospitalization, whether that's continued care or ultimately in discussion with the critical care team or palliative to explore options for end of life. But it's very important in PA cases and in patients that have experienced successful resuscitation by decompression of the chest to give them a period of time to assess whether or not the brain has been injured or even permanently injured. There's no way to really know without allowing the elixir of time to proceed.
What period of time would you have suggested for her?
I mean, certainly the shortest period of time would have been 48 hours or 2 days, and preferentially I would have counseled the family that 72 to 96 hours would have been the ideal situation, but at least given the family some range within which to work with and understand that we could make a reasonable and prudent assessment at 2 days or 48 hours, but to get the really accurate assessment and to complete the workup would probably take 3 or 4 days.
Were there any tests or procedures that either pointed to a good or not so favorable outcome for Ms. Austin?
Well, certainly in Mrs. Austin's case, as I mentioned already, the fact that early on that she had an adequate capnography during CPR points to a good outcome.
What is that again? I think you told us yesterday, but could you tell us again?
So capnography is the actual measurement of carbon dioxide coming out of the lung, going into the windpipe, and coming out of the breathing tube. And what EMS or the emergency room does, they put the gauge that measures that between the breathing tube and the breathing circuit. So as the carbon dioxide comes out, it will give you a number and it will quantify that. And that gives us an indication. Again, if the CO2, which is in normal patients, 35 to 45, if it's able to be maintained in the high teens or low 20s, that's very favorable. If it's less than 5, that would point towards a more unfavorable prognosis because it would at least imply that there is less than adequate blood flow going to the brain. Additionally, in looking at her ventilator settings, Ms. Austin was breathing above the set ventilator rate, which would mean that she's not brain dead, because if you're brain dead, you can't breathe above the set rate. So in other words, brain death itself means that there's complete death of the lower part of the brain. So that also speaks, at least generically, that there's not brain death and there may be a chance for her to regain consciousness and participate in her own healthcare determination.
Is there anything about her heart rate that would inform your thoughts?
Yes, Ms. Austin, once the chest tube was placed, showed dynamic variability of her heart rate. So in patients that have the dynamic variability, that would imply that the patient could potentially sustain spontaneous functioning of the heart moving forward.
Was there a time when a discussion of her DNR became appropriate or happened?
Well, yes, certainly, again, given that a patient had an outpatient cardiac arrest and the events that unfolded, I have no criticism of discussing DNR with the next of kin because there is a possibility that the patient could have another cardiac or cardiopulmonary arrest. So it's always wise to engage in that discussion. But as mentioned, I feel in reviewing her chart that it was too early to conclude that her prognosis was terminal or that further intervention was futile. So in terms of actual withdrawal of support, I would not have supported it.
Thank you. Have you reviewed any pain scoring for this patient?
Yes, this patient had limited entries in the medical record on pain score, and at least the one that I recall that occurred in that evening around 10 p.m. showed that she was not demonstrating pain, that it was, I believe, a 0, and her Glasgow Coma scale was essentially 3.
Was she responsive on any level that?
No, not according to the documentation of the nursing staff, she was not demonstrating any responsivity.
Okay. Was there a time when she was extubated?
Yes, she was then terminally extubated on the late evening of September 30th, which was the day of admission.
And what medications were administered at the point of extubation?
The order was placed for Miss Austin to receive 600 micrograms of fentanyl, and that order was placed at 11:10, and the action was apparently a minute later by the nurse. And then simultaneously, an order was placed for 6 milligrams of Versed, and those times were at around the same time.
Was there any legitimate medical reason for these doses?
No, in reviewing her chart and the acuity of her deterioration, I could not identify any medical justification for the patient receiving these medications, particularly given that she had only been brought to the ICU at 9:47 p.m. So essentially less than an hour and a half before these orders were placed.
What level of analgesia do you feel would be appropriate for this lady upon extubation?
Again, assuming that the terminal extubation was justified, and given the fact that up until that point, she did not demonstrate any acute pain issues or agitation, and that the one pain score was a 0, certainly the lower end of the spectrum would have been prudent. I think certainly one could justify the dose of 100 micrograms of fentanyl or less. Again, since she was not demonstrating any signs of agitation or anxiety, I don't believe that anything more than 1 of Versed would have been indicated at that, because again, given that her cardiac arrest had preceded that and she still appeared to be comatose, it would not warrant more than that level of medication.
Thank you. And in your opinion, did the dosing of fentanyl and Versed hasten or cause her death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, the decision to administer 600 micrograms of fentanyl and 4 milligrams of Versed at the time of the palliative extubation, which occurred at 23:30, according to the notation, did cause and or contribute to hasten Miss Austin's death, and which was documented to have occurred 23 minutes later at 11:53 that evening.
Thank you. In your opinion, does the doctrine of double effect have application in this case?
No, in my professional opinion, this case does not support the application of the doctrine of double effect. As mentioned, Ms. Austin had just recently been admitted to Mount Carmel West. She had been successfully resuscitated. A period of observation and support was indicated. So this action of proceeding rapidly to palliative extubation and withdrawal support shows absolutely no moderation in the case, and the administration of the fentanyl and Versed shows no proportionality. So I do not believe this case supports the doctrine of double effect.
What actions or lack of action taken by Dr. Hussel speak to his intent in this matter?
So starting with the lack of action, again, given what I've just testified to today, which was that this was a PEA arrest, the heart did stop, but due to a pneumothorax, it would be mandatory to observe this patient to see what the impact was of having placed the chest tube, re-expanding her lungs, giving her a time to equilibrate on the ventilator and assess how severe of a lung injury this would be, or if there would be any permanent leak in her lung. Again, that would take time. You could not determine that even within a day or two. That would usually takes 3 or 4 days to try to wean someone from the chest tube and put them on water seal to see whether there's a permanent hole or leak in the lung. But certainly you can't do that in a few hours in a patient like Ms. Austin. Secondly, attempt to try to comprehensively work up her underlying cardiac situation. It's irrefutable that she had multiple cardiac arrests. I certainly see that in the record. But what residual damage the heart had from the CPR was not determined. The only way a doctor could determine that is to get echocardiography, to take pictures of the heart and see how well the heart is contracting. And that was not done. There was no attempt to order a 2D M-mode echo through the chest. Similarly, there was no attempt to put further invasive lines in the patient. If one is not going to image the heart through the chest wall, then there are means that you can go through the neck and put catheters in the heart to see how well the heart is squeezing. That too was not done in this particular case. And then to at least give the patient 24 to 40 hours to see whether there'd be any improvement in her neurological condition. Certainly on this date, she was comatose, but based on the fact that this was relatively rapid, and many patients who suffer cardiac and pulmonary arrest will have a period of anoxic encephalopathy, one would need to give a period of time to declare how much brain function was remaining. So the absence of doing that certainly speaks to the intent in this case. In terms of the proactive issues in this case of intent, given that there was no documented pain in the patient predicated by objective observation of the doctors or nurses, her pain score was a 0. I see no indication to support 600 micrograms of fentanyl. And in my mind, that speaks to intent. And then given that the patient was essentially a Glasgow Coma scale of 3, she was comatose, the administration of 4 milligrams of Versed in this case, or 6 milligrams of Versed would appear to be justification of intent in this case.
Thank you, doctor. I can go to another
Let's take a break.
patient or a break.
Ladies and gentlemen, let's come back at 3. Okay?
All rise.
Enjoy your break. Remember the admonitions. Have a good break, guys. You may be seated. Doctor, you can go ahead and step off. Remember the admonitions earlier?
Yes, Your Honor.
Ms. Grubb, anything for the record?
I don't believe so, Your Honor.
Ms. Menashe?
No.
Okay. We're on break until continue on with the testimony. Doctor, you're still under oath?
Thank you, Your Honor.
Ms. Grubb.
Dr. Schweiker, we're now going to turn to the matters regarding James Timmons. Did you review Mr. Timmons' medical records?
Yes, I set out to review him in the totality of the medical records that were provided prior to authoring my reports.
Thank you. Were you also provided with a coroner's report after reviewing the medical records?
Yes, I was after.
Were you provided with a coroner's report after you wrote your report in this case?
Correct. I did not receive the coroner's report until after I wrote my report.
May I approach Your Honor?
You may.
Handing the witness State's Exhibit 18-0. What is that, Doctor?
This is the coroner's report from the Franklin County Coroner's Office investigating the death of James N. Timmons on October 24th, 2018.
Thank you. Did you review it?
I did, yes, ma'am.
What did you find upon your review in that report?
So the key findings in the coroner's office report included, number one, that there had been recent utilization of cocaine and fentanyl in the patient, that he had severe underlying pulmonary edema on the autopsy, that there were both recent and remote needle tracks that indicated the portal of entry for his drug usage, and that the associated findings that were described that by the autopsy was systemic shock involving the whole body, acute renal failure, meaning kidney injury or kidney failure. He was status post-surgery on the left lower extremity, after which they had opened up the leg to release the pressures in the leg, secondary to compartment syndrome. The toxicology, which was the blood drawn before death anti-mortem, it indicated that there were numerous substances detected. They found the metabolite of nicotine in his body, indicating he was a smoker. They found the drug ketamine, which is a medication administered and also at times abused. They found norketamine, which is the metabolite of ketamine. They did not find cocaine in the blood acutely, but it did appear that there was some metabolites of cocaine that he had previously taken. There was no detection of the acute concentration of marijuana, which is THC, but there were some metabolites present in the blood. And then going down, it did show the presence of fentanyl in his blood, the nicotine and nicotine metabolites that I mentioned, and then the multiple metabolites of the ketamine. And then on the final page of the toxicology, it revealed positive for cocaine and benzoyl ecogene and methyl ecogene, which are metabolites. So ultimately, the pathologist in coroner's office concluded that the cause of his death was recent cocaine and fentanyl abuse, and they ruled the manner of death an accident.
Thank you. Was the blood tested anti-mortem or post-mortem?
The coroner's office indicated that the sample was anti-mortem and that it had been obtained on October 22nd, 2018 at 21:47 military time, so essentially 9:47 p.m. on October 22nd, 2018. So prior to his death.
When was he admitted to the hospital?
Mr. Timmons had been admitted to Mount Carmel West on October 22nd of 2018.
Thank you. And what were his complaints upon admission?
So Mr. Simmons had been, as is indicated here in the notation, he had been found down at home, presumptively by a roommate, without really a recollection of what had occurred overnight. He was, however, at that time discovered with needles nearby, so the presumption was that he had been abusing illicit substances, probably through injection, and had then lost consciousness for some period of time and had been essentially not moving. So what is indicated here when he presented, first of all, he was very cold. You can see the word hypothermic means that his core temperature was very low. Also, he had little blood sugar in his body. Normal blood sugar is between 70 and 110, and he was at 29 in his blood. He had received multiple doses of Narcan as part of the resuscitation, and also dextrose, which is sugar. The vital signs that are demonstrated here confirm his hypothermia. They also confirm a very low systolic blood pressure. Normal would be 120/80. His was 47. But more importantly, they found that he had what is known as rhabdomyolysis, and that means that he had significant muscle breakdown, likely because he was laying in one place for too long from having passed out from the drugs. And here we see leukocytosis, means markedly elevated white blood cell count, but life-threatening was the serum potassium, which normally is between 3.5 and 5. His was essentially double that at 9.1. And that occurs because when muscle dies and breaks down, it releases potassium from inside the cells into the blood, and that can be poisonous to the heart. His buffer, the sodium bicarbonate, which is normally 22 to 26, was cut by more than half. It was 9. And the difference in his anion calculation, which normally is 6 to 10 or thereabouts, had essentially more than tripled to 33. Very frequently, when a patient has severe rhabdomyolysis, the muscle protein will poison the kidney. And that's what we see here. His creatinine, which for his age should have been less than 1, was at 3.47. So he was presenting an acute renal failure. And then his liver also had been injured. So that's why I wrote increased liver function test. And CK is that protein in the muscle. That's creatinine kinase. Normally should be less than 100. His was greater than 5,000. And then he had lactic acidosis, so that since he wasn't getting enough sugar in his blood, he was going through that process of trying to create energy without sugar. And that's why he was making lactate. And then the initial UDS, which stands for urine drug screen, which was done because of this description, tested positive for cocaine and for metabolites of marijuana. So they listed here that he was immediately given a consult by the kidney doctor, the nephrology, because those numbers were so high and the potassium so high that it could easily stop his heart. So they were getting urgent dialysis in, and they were going to transfer him to the ICU in order to achieve that.
When did he go to the ICU?
So he went to the ICU relatively rapidly because he needed to have vascular access, meaning he needed an ICU doctor to be able to gain access into the big veins of the body in order to perform the dialysis. Without that, you couldn't do it urgently. So they tried to transfer him as rapidly as possible to the ICU. Unfortunately, during that process, before they could really purify his blood, he suffered what's described in his record as a sinusoidal code blue. And what sinusoidal means is that on the EKG, it has the waves of the ocean. So rather than the normal spikes you see on an EKG, when you have very high potassium, potassium poisons the heart. We should have low potassium in the blood, but high in the cells. When it gets in the blood, it interferes with the electrical system of the heart, and you start to see these very aberrant waves, again, that almost look like those waves on the ocean. So that resulted in him rapidly deteriorating.
Thank you. Did he code again?
Yes, he had essentially the first, and then he was resuscitated, and then he had another essentially code related to not only the potassium, but likely the worsening of the acidosis due to his kidney failure and the shock, because as the body makes more acid, it actually pushes more potassium out of the other cells, and that just worsened his underlying condition.
Thank you. How did his ICU course progress?
So again, initially there was an evaluation that was undertaken to assess his status, and I believe he was seen by Dr. David Ralston, who is also one of the critical care doctors at Mount Carmel West, who conducted the assessment of the patient. There were really two life-threatening issues in Mr. Timmons. Number one, I've already discussed the high potassium and the cardiac arrest. The second was concern that he had laid in one position so long that he developed what's known as compartment syndrome, that the muscle within his leg was essentially dying. And when that happens, it swells from the inside out. So it's almost like you may have seen if you cook a hot dog in a microwave and it just spreads so long until eventually the skin of the hot dog ruptures. If that muscle gets so swollen, it continues to swell, and eventually that will cut off the arterial system, so they'll lose sensation. It'll cut off the neurological sensation, so they won't have pulses, they won't have pain, the leg will be blanched because you don't essentially have perfusion, and that will cause further muscle breakdown. So there was a stat consult placed to orthopedic surgery, Dr. Nicholas Wilson and Dr. Stephen Gaines, that is described on the bottom of page 8 and the top of page 9, in which they were evaluating him for this compartment syndrome. Because what an orthopedic surgeon will do is usually take the patient to the operating room and they'll open the fascial compartments up of the leg surgically. So that will allow expansion of the muscle, and that may potentially save the muscle inside of it. It's not always able. If the muscle's already dead, you can't bring it back, but it will usually at least give the patient the best chance. So that was done, and they did do a lower extremity fasciotomy. And I described that on the top of page 10, where, again, they talk about emergency need for a 4-compartment fasciotomy. There's 4 compartments to the lower leg, and they felt it was indicated to open all 4 up.
Thank you. Doctor, what is your evaluation of the salvageability of Mr. Timmons?
Once again, Mr. Timmons was seriously ill. He was life-threatening ill, and he absolutely needed to come to the ICU. So there's no question that the doctors in the emergency room did the right thing by getting him to the ICU. These are 2 or more life-threatening conditions. At the same time, he did present to the hospital awake and alert. So that he was certainly not dead on arrival when he came there. So this is the type of patient that I described earlier that needs a period of time to evaluate. First of all, to see whether the lower extremity fasciotomy, opening the leg up, can salvage muscle of the leg, or whether a part of the leg, whether that be the foot or below the knee, needs to be amputated in order to save the patient's life. Also, given the fact that he had not one, but two cardiac arrests, but that there was a clear mechanism for the cardiac arrest being the elevated potassium, he would fall into that category that he may regain consciousness, he may be able to at least survive this event, albeit with major support. He needed dialysis, he likely would need ongoing fluid and pressor support, but I would have counseled his family to give him 48 to 72 hours to see what his salvageability was, and again, allow his body to declare to me as the physician and to the team how severe his end organ status was.
Thank you. What medications did he receive?
May I look at the Mars real quick? Thank you. So when he first arrived at Mount Carmel West, the treatment team initiated what's known as the hyperkalemia protocol. And in doing that, what you do is you inject the patient with insulin, because even in the non-diabetic, if you give the patient insulin, it pushes the potassium back into the cells. It's kind of a side effect of insulin. So we can see on the first page of the Mars that he was given an insulin sliding scale. Also, because of this tremendous swelling in the lower extremity, he was administered heparin, which is a blood thinner. Because the swelling of the leg is painful, particularly if there's viable muscle there, you literally feel like a boa constrictor is wrapping around your leg. So he did report some initial pain. So they gave him at 11:58, there was an order for 100 micrograms of fentanyl that had been ordered. There also was an order, I think a little later after midnight, for 2 milligrams of Versed to be given. And then he was essentially assigned later on, I think, administration of sodium bicarbonate. And essentially, that's an alkalinizing or neutralizing substance. Bicarbonate will bind to acid and will help take that out of the system and then be excreted in the kidney, or in this case, it would be washed out in the dialysis. And then we see additional indications for small amounts of fentanyl. At 5 in the morning, they gave him 100 micrograms of fentanyl. He also had another order for 2 milligrams of Versed. Then on the 4th page of the Mars, we see that he was ordered by Dr. Hussel, and this was appropriate, a drug called calcium chloride. When the potassium is high and it's going to poison the heart, the antidote, besides trying to push the potassium into the cells with insulin, is to give calcium chloride, which will stable the heart. So that was ordered at 6:54 in the morning and was received. Also, he was at risk for a bleeding ulcer because of the stress and the drug abuse, so he received Protonics as part of that therapy. He was given some topical medication because of the leg. And then we see the orders placed for more calcium. They started him on antibiotics because once his leg was opened up, he would have been vulnerable, because you're basically slashing the whole leg open. This is not a minor incision, and you're not suturing it shut. You're just leaving it open until the swelling is done. So he received cefepime at 11 a.m. on the 23rd.
Doctor,
Yes.
can we turn to the administration of any pain medication through virtue of surgical procedure or infusion?
Yes, certainly. So we certainly see that he did receive the medication fentanyl by the certified registered nurse anesthetist. In this case, it was Patrick Turner, who worked in the OR as the CRNA, and that was under the supervision of Dr. And I apologize, I mispronounced it, but Chiramamila, who was the anesthesiologist. And we see that he received from that team incremental fractionated fentanyl administration during the fasciotomy.
Can we stop right there?
Sure.
And may I look at the page that you're...
Yes, ma'am.
We'll note that there's some numbers there, 14321, and then a microgram number. Can you explain what those numbers are?
Yes, so what that indicates is that the anesthesia team was providing this pain medication to Mr. Timmons on an infusion. And what is indicated here on the MARS, again, there'd be more detailed information on the anesthesia record, but the MARS is kind of the summary. So what we see is that the patient received, according to this documentation, 14,321.249 micrograms that were dissolved in a total infusion of 286.42 mLs.
Was that entire amount infused? Can we tell?
No, from this you can't tell. What we can see is the constitution of the drip that was put forth, and then one would study the anesthesia record to assess how much of that infusion was given to the patient.
Okay. And how long was that surgery, if you know?
My recollection, and it's been a little while since I looked at the surgical and operative, but that it was approximately 2 hours.
Okay. And would it be reasonable to receive that amount of fentanyl in 2 hours?
No.
Turning to the infusion record, continuous infusion record, can you talk a little bit about whatever continuous infusions he may have been receiving?
I think there may be a few missing pages, because I have the bottom page, but I think there was. Do I have it all? Okay, well then I have it all. So that being the case, the continuous infusion that's documented was the drug dopamine, which is a mixed vasopressor and inotrope that is meant both to increase the patient's blood pressure, but also increase the squeeze of the patient's heart.
Was there any other pain medication applied? Continuous infusion.
I mean, that's what I'm saying. I think there may be another sheet because I don't see it listed here. He did, as I said, there were some additional entries regarding the fentanyl that was administered earlier, but I don't see on this sheet any listing specifically of continuous infusion.
So, did you also review the pain scoring?
Yes, ma'am, I did.
Presenting you the pain scoring list, which is.
Thank you.
Have you reviewed?
I have, yes, ma'am.
What does the pain scoring inform us of?
So in looking at the pain scores that are documented, the initial pain score when he entered was a 0, but then shortly thereafter, and I believe my memory is it was at 6 p.m. and at 8 p.m. He did report a 10, which is consistent with his presentation because, again, he was having this compartment syndrome. He was regaining consciousness after being down for an unknown period of time. But after that entry of the 10, then all of the remainder pain scores were 0.
What happened to this gentleman after the surgery?
So after the surgery, he again showed some continued deterioration. There was concerns about shock liver, that the process that had been unfolding, coupled with the change that had gone on, that had resulted in the dying muscle, had impacted the perfusion to the liver, so that was concern. There was obviously the concern about the impact of the medications, the drugs that he had ingested or had injected at that particular time. There was the consultation placed by the kidney doctor that agreed. It was in the evening of October 22nd, where they had indicated that they were going to obtain and start the dialysis. There was also indication that they wanted to obtain imaging of Mr. Timmons' heart with the echocardiogram, because again, since he had been injecting medications, he was at high risk for endocarditis of the valves. So they wanted to get blood cultures, they wanted to get the echo to rule out vegetations or endocarditis. They also were going to order blood and urine cultures. And again, Dr. Ralston from Critical Care, and this is on the bottom of page 6 on my report, all the way through the bottom of page 8, wrote a detailed description of his findings during the initial assessment. And he also on page 8 discussed his update that he gave Dr. Hussel. So he saw the patient initially and then gave a verbal report to Dr. Hussel, particularly regarding the need for the dialysis access, because Dr. Ralston hadn't been able to put in the catheters and was going to defer that to Dr. Hussel.
What lab values was he showing as he progressed?
So he was showing worsening of the acidosis. He was showing certainly signs that the kidney function had been impaired by the impact of the injury. We see that even after the arrest and after the dialysis, then this is on page 13 of the note, that he had a serum potassium. It had come down from 9.1 to 6, so it was progressing in the right direction, but that was still elevated. His carbon dioxide or bicarbonate was still low at 17, but had improved from 9 to 17. His kidney function with the dialysis did show some minimal improvement. He had a marked increase in his white blood cell count at 21.6. And then he also showed an upward trend in his hemoglobin and hematocrit, but that was probably related to how dehydrated the patient was upon arrival.
Thank you. At some point, did this gentleman's DNR status change?
It did, yes. So after, as I mentioned, Dr. Hussel did place the dialysis catheters into Mr. Timmons. In fact, there was an arterial line placed in the wrist. There was a central line placed, and the dialysis catheter. That was all done on the evening of the 22nd. As we already discussed, the patient had surgery. But then in the early morning hours of October 24th, there appeared to be an abrupt change in the direction of the therapy, and the order for full resuscitation was canceled, and an order for the DNR comfort care measures was placed.
Was there then a move towards extubation?
Correct. After the DNR order was placed, and that was timed at 2:37 in the morning of October 24th, there was thereafter an order placed at or around 3 a.m. for 1,000 micrograms of fentanyl. additionally, at that time, there was an order placed for 10 milligrams of Versed. And then 5 minutes later, there was an order placed for at 3:05. So the first 2 orders were at 3 a.m. 5 minutes later at 3:05, there was an order that I found in the chart placed for 10 milligrams of Dilaudid, and then an order placed at 3:05 for 20 milligrams of Versed underneath that. And then 18 minutes later at 3:23, there was one last order for 10 milligrams of Versed.
So, do we know then how much in the way of opioids were administered?
Yes, in looking at the MARS, it appeared that the patient did in fact receive 1,000 micrograms of fentanyl, and then received, subsequent to that, received 10 milligrams of Dilaudid.
What about the Versed?
The Versed, let me just find it here. So there's confirmation in action details that the first order of 10 milligrams of Versed were administered. And then additionally, it appears that the second dose of 10 milligrams of Versed were received.
How much time was elapsed in between the two opioids?
So between the two opioids, the orders were apparently given 5 minutes apart. And according to the documentation of the action details, which is the action of the nurse following the orders, they were essentially documented to have been given at the same time, both administered at 3:24 a.m.
And what is the equivalent dose in fentanyl to this amount of hydromorphone or Dilaudid?
So in terms of equivalency, the administration of 10 milligrams of Dilaudid is equal to an additional 1,000 micrograms of fentanyl. So it would be essentially equal to giving the patient 2,000 micrograms of fentanyl.
Thank you.
We gotta make sure they're not mixed in.
Yeah, sorry. Okay, so these are all the continuous infusions. All right, I mean, we've got those pages. Doctor, I'm handing you a stack of documents. Would you please tell us what those are?
So this stack of documents is what I recall, that there are multiple pages in Mr. Timmons' records that chronicle the continuous infusions he received during his essentially 2+ day tenure at Mount Carmel West. It lists the various medications that were being continually infused into the patient.
Thank you. Can we address our attention to the fentanyl?
So I find multiple entries regarding fentanyl infusion in the patient.
Okay, thank you. And is it easy to calculate how much he received during his hospitalization?
It's not easy because there was alterations in the rate of infusion to the patient. So for example, the first entry that I see in the medical record includes a fentanyl infusion that was ordered at 25 micrograms per minute. And then there's an action detail that talks about an infusion of 30 mLs per hour. And again, it lists the ingredients on the top of that infusion. Then later on in the chart, there is a change on October 23rd at 8:12 in the morning. There appears to have been a change, at least indicated here in the, under the ingredients section, where there was, it's identified as a rate change. But again, this electronic medical record can be somewhat confusing in terms of what is indicated, because it lists, again, with a code, the FENT50IT, and then 300 mics per hour. But then below that, it still is listing the rate at 30 mLs per hour, which was actually, I believe, the rate that the earlier rate was placed. So there are some confusing entries in the MARS.
Would it be expected that this patient would have pain?
Yes, certainly a patient that had compartment syndrome with injured and potentially damaged muscle would likely have pain. So that is true. And then the fact that he underwent surgery with the fasciotomy would also be consistent with a patient who would have some element of pain.
Do you find these infusions to be appropriate?
Yes, even with slight editorial confusion in terms of some of the rates, certainly the actual infusion rates that were indicated here appear appropriate for a patient who presented with Mr. Timmons' problems and the need for going to the operating room.
Thank you. Do you feel that the discussion of his DNR-CC was appropriate?
Yes, he presented with major medical problems and he had multi-system organ dysfunction. So I think a realistic discussion with his next of kin regarding his outcome was appropriate, and certainly entering a DNR order at some point was certainly reasonable.
Thank you. Do you believe the timing of the palliative extubation was appropriate?
In my professional medical opinion, the timing of the palliative extubation was not appropriate, given that he had undergone surgical exploration and fasciotomy, that he was receiving support for his underlying organ function, that although there were abnormalities in the labs, despite the fact there was dialysis, they were in fact improving, and that he needed ample time to declare the severity of the neurological injury he may or may not have suffered during those 2 code blues. It appeared too hasty to just progress immediately to withdrawal of support and a terminal extubation.
Thank you. Based upon his overall medical condition, his history as a drug abuser, and the toxicology report along with the infusions that he received in the hospital, what is your opinion as far as the appropriateness of the dosing offered and administered to this patient at the point of his extubation?
Within a reasonable degree of medical certainty, the doses that were provided were in excess of what the patient warranted based on his pain scores that had, after his code, been 0, and the fact that, again, he remained comatose and was not demonstrating either acute anxiety, agitation, or pain. Certainly, based upon all the information available, Mr. Timmons would have had a requirement for some increase in his analgesic requirement. So certainly, if one were going to order fentanyl for terminal extubation, I think a dose in the range of 300 to 400 micrograms would have been indicated based upon his history of drug consumption. In fact, he had been apparently exposed to various various illicit drugs over time, and he had been exposed to fentanyl while in the hospital. But certainly to order the 1,000 micrograms of fentanyl combined with the Dilaudid did not seem to be indicated based upon his clinical condition in the ICU or the documented pain scores.
Thank you. Do you see any legitimate medical reason for the dosage administered to this patient at point of extubation?
No, at the point of extubation, I do not see medical justification for administering 1,000 micrograms of fentanyl combined with the 10 milligrams of Dilaudid, which in essence equaled 2,000 micrograms of fentanyl. As I mentioned, it was reasonable to expect that Mr. Timmons would require more than the average patient, but the appropriate step would have been to administer, as I said, 300 to 400 micrograms of fentanyl is a large dose. And so for his history of drug abuse and his presentation, that should have been adequate to control his pain, with then subsequent orders as need be to allow the nurses to titrate more if in fact he demonstrated any pain or discomfort following the decision to terminally extubate and remove life support.
In your opinion, did the dosing given here, the 1,000 micrograms of fentanyl plus the 10 of Dilaudid plus the midazolam, hasten and or cause his death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, given the timing of the administration of the fentanyl, the Versed, and then as well the Dilaudid, it does appear that this did accelerate, thus hasten, the demise of Mr. Timmons following the removal of the endotracheal tube and withdrawal of support. And that's particularly true given the fact that he had experienced the renal dysfunction, he had experienced the shock liver as a result of the drug overdose and the concomitant findings, that there was really no period of equilibration in his body to give the fentanyl that was even administered time to work, let alone see what the effects would have been before moving to give Dilaudid, which was a second opioid that would likely have exacerbated the respiratory compromise induced by the fentanyl.
Thank you. In your opinion, does the doctrine of double effect have application in this case?
No, in studying this case, I essentially concluded that this case, again, does not demonstrate or document an appropriate application of the doctrine of double effect. As I've mentioned many times, Mr. Timmons was very sick and he had a very questionable prognosis based on all that has been discussed. But again, one has to use proportionality. There was no indication to administer both fentanyl and Dilaudid to this patient at the time of the terminal extubation. Administering one of those and then assessing the effect would have provided moderation and prudence. Similarly, the comment about the Versed, which was given as a sedative in this case, and given the fact that he had remained in coma and was not responsive and not reporting pain, it would not, this intervention would not be consistent with the doctrine of double effect.
Thank you. What actions or lack of actions taken by Dr. Hussel speak to his intent in this matter?
Well, first, again, given the complexity of his psychosocial presentation, Mr. Timmons definitely required a palliative care consult. Again, not only was he found down without any really reliable history, so the circumstances were certainly questionable, but again, his life positions required really a careful assessment by palliative care and social work as to what would have been likely outcome should he survive this hospitalization moving forward. Again, also, since there was really a multidisciplinary approach in terms of his initial hospital stay, including not only the kidney doctor for dialysis, but orthopedic surgery, but should have included those services in a discussion as to whether his limb was salvageable and whether his life was salvageable, or if in fact all of these things put together would have hinted at a terminal status. So the failure to consult and wait for palliative care, the failure to organize a multidisciplinary conference to assess the situation, and then to proceed with terminal extubation and withdrawal of support certainly implies intent, in this case, to hasten the patient's ultimate death. Additionally, the decision to give 2 powerful opioid medications in combination with the Versed and not to allow a period of time between the administrations to adequately assess the effects of the opioid and the Versed also speaks to the intent that the goal was to hasten the patient's respiratory compromise and ultimately apnea, which would lead to the patient's death, given his tenuous underlying kidney, liver, and bodily function.
Thank you. Okay. Let's turn now to Sandra Castle.
May I just give you this back to you so you can keep it?
Oh, sure, thank you.
Yeah.
Okay. Doctor, did you review the medical records for Sandra Castle?
Yes, ma'am. I did review the medical records of Sandra Castle while a patient at Mount Carmel West.
And did you write a report in her case?
After I reviewed her medical records, I did in fact write a report.
Okay. What was this lady's presenting problem?
So Ms. Castle's presenting problem centered around her heart. She had a witnessed cardiac arrest at home. Her son initially called 911 to summon EMS to the house, and then immediately proceeded to start CPR on the patient. So this again categorized as a witness out-of-hospital cardiac arrest. When EMS arrived, they found on the EKG monitor that she was in ventricular fibrillation and that she required several shocks to try to restart her heart, but they were unsuccessful. What it did do was it converted her ventricular fibrillation to tachycardia, ventricular tachycardia. Thus, they gave the administration of amiodarone, 300 milligrams, shocked her again, and this time they were able to return a pulse. Since she was an out-of-hospital arrest that had been witnessed, and since she had ventricular fibrillation, it was decided that she would be an excellent candidate for therapeutic hypothermia, meaning that the team would cool her in order to preserve brain and neurological function. So she was supported on a blood thinning drip, the heparin, and also put on a vasopressor drip, the Levophed. And as may often happen in patients who have cardiac arrest and develop anoxic encephalopathy of the brain, she started manifesting facial twitches that concern them. This can be described either as abnormal seizure activity, or more appropriately, it's referred to as myoclonic twitching, because it's not a true seizure on the EEG, it's more a result of the temporary injury to the brain. And so as a result of that, cardiology then investigated her pacemaker, which had been implanted in her previously, and they found that she had had ventricular tachycardia previous to the arrest. So that was likely the reason that she had this event. And then she, of course, was admitted to the ICU.
Thank you. In your review of this lady's medical history, and records, did you feel that she had a salvageability?
So neurology was consulted at Dr. Alexander, who did raise the concern about anoxic encephalopathy of the patient, which would be injury to the brain due to lack of oxygen during the code. Again, there were discussions with the son about this, and in fact, Dr. Adam Mahoney, one of the intensivists, had entered in his note that there had been a discussion about a palliative withdrawal of the patient, and an order was placed for a palliative care consult as well as a DNR comfort care prior to the patient being extubated.
Thank you. What happened then?
So at that point, because the patient had manifested essentially a abnormal Glasgow Coma scale of 3, it was basically determined that she had been comatose during that period of time. And as a result of some of the facial movements and twitching, she had been administered on November 13th, 2018, various medications. She had gotten small amounts of morphine. She had also gotten Ativan. The patient had been extubated on the afternoon of November 13th at around 4:52. And then I noted entries for the Ativan and morphine at 6:33, at 7:03, at 7:33. And then further on, again, later on, there was the nursing transfer between the day shift and the night shift that addressed the decision for the extubation. And then later that night, there were additional doses of Ativan and morphine given to the patient. At or around then the 10:57 mark, it appears that Dr. Hussel was called, and then he placed an order for 1,000 micrograms of fentanyl in the patient. And then that was subsequently administered along with 10 milligrams of Versed.
So when this condensed history says that she was extubated at 16:42, that is a day shift time, correct?
Correct. In the ICU, the standard time is 7 a.m. in the morning, or 0700, through 7 p.m., which is 1900 hours. So as is indicated here in the medical record, 1642 military time means 4:42 in the afternoon. So this would be the day shift.
Do you believe that Dr. Hussel ordered that extubation?
No, I don't believe Dr. Hussel was working the night shift. So this extubation occurred, I believe, at the discretion of the physicians that were seeing her on the day shift, and they had ultimately agreed that there would be this extubation.
Thank you. Did you review her pain scores?
I did, yes.
And what did they reveal?
So there were variable entries, and may I just review them quickly before I comment on them? Thank you. So a review of the pain scores revealed that after she had first arrived, there was one pain score of 10. Thereafter, her pain score went to 0 and was consistently 0 on November the 10th, November the 11th, the November the 12th. And then the first indication of an uptick in the pain was shortly after midnight on November 13th, where an 8 was assigned. And then after that, there was no documentation of the pain score until 8:30 in the morning, when Ms. Castle was once again given a 0. And then at around the time of extubation at 16:34, she was again given an 8, and then thereafter variable, there was a 9, an 8, a 9, and a 9.
The one
The report that you have in the notebook on this patient?
report. This,
Yes, yes. Thank you. I'll make sure that we don't want to issue it in this. One moment, Your Honor, please. Sorry, I didn't go. Just want to make sure that it wasn't changed.
no, no problem with that. At some point, was there a discussion of her DNR?
Yes, prior to the decision to extubate the patient, there was a discussion reflected in her medical record, and the decision was made to proceed with a DNR status.
Thank you. And do you feel that that was appropriate?
Yes, given.
I'm sorry, is it your opinion that that was appropriate?
Yes, it is my opinion that based on both her advanced age and the sequence of events that are described in the medical record, that certainly it was reasonable to assign, after discussion with the next of kin, a DNR status in the event that she would succumb from this event. Further resuscitation would unlikely have provided any benefit to Mrs. Castle.
Thank you. Do you believe that the palliative extubation in this case was appropriate?
Yes, given the totality of the findings in the medical record, coupled with her advanced age and the underlying disease states she had, the decision to palliative extubate the patient at 4:42 was medically justifiable.
What is your opinion with respect to the dosing of medications attendant to the extubation and thereafter?
So the initial decision at or around the time of extubation to provide the patient with 100 micrograms of fentanyl was certainly within a range that could be medically justified. Thereafter, after she was extubated, as I mentioned, she received morphine and Ativan, and that certainly was also consistent with compassionate care. The doses were on the lower side. She was ordered 4 of morphine and 2 of Ativan. There was then, exactly as I discussed, incremental fractionated increase. It went from 4 of morphine. Later on, they then increased it to 10 of morphine. That's still within a range that would be considered medically justifiable to avoid any experience of pain. But then when we get to the evening hours, the order placed by Dr. Hussell for the fentanyl combined with the Versed, that would not appear to be medically justified.
Was there any legitimate medical reason for this dose of fentanyl?
No, ma'am. At that point in the evening, Ms. Castle had successfully survived the terminal extubation. She was being provided both pain medication and appropriate sedation in the event that she was experiencing any discomfort or any agitation related to the terminal extubation. But from that period of 4:30 when she was about to be extubated up through the time that the order was placed for the fentanyl and the Versed, I couldn't find any significant documentation that the patient was in any way demonstrating abnormal physiologic responses that would justify such a rapid escalation in the doses of fentanyl and Versed that evening.
What purpose could this dosing serve at this level?
Well, given that there was no medical justification for 1,000 micrograms of fentanyl or 10 milligrams of Versed, and that she was elderly, more likely than not, within a reasonable degree of medical certainty, it would rapidly penetrate the brainstem, reducing her ability to spontaneously breathe from that point forward. It would also make her insensitive to the rise in carbon dioxide within her body, which would further blunt her response to breathing once the carbon dioxide elevated. So in terms of the intent, it would appear that the intent of administering fentanyl and Versed was to cause apnea, which would then hasten the patient's death rather than allow a natural death to occur, as was initially ordered by the palliative extubation and the 6 or so hours where she breathed on her own.
Do you believe that this dosage, in your opinion, did the dosing of the fentanyl and Versed cause the death of this woman?
Yes, within a reasonable degree of medical probability, the administration of 1,000 mics of fentanyl coupled with the 10 milligrams of Versed hastened Mrs. Castle's death on the evening of November 13th. Certainly, I agree with the doctors that were caring for her that she was entering a terminal phase, and certainly allowing her to progress to a natural death was certainly justifiable, but the acceleration of the death by the fentanyl and Versed does appear to have been the causative factor as to when she actually died at 11:20, which was in essence a little more than 20 minutes after those two orders were placed.
Thank you. Doctor, I'm approaching with State's Exhibit 32N, which is your report. Could you please address in the report your opinion as far as who extubated this patient?
Yeah, so on page 20, in the verbiage, it appears that I attribute the extubation of Ms. Castle to Dr. Hussel, and that would be inappropriate. And looking further at the chart, the extubation actually occurred prior to his arrival that evening for the case.
Thank you. Anything else you want to address in the report?
So on page 17, the phrase, additionally, Dr. Hussel ordered medication to induce a terminal extubation is incorrect. Obviously, since he didn't participate in the terminal extubation, that sentence would have to be retracted because he did not participate in the actual decision for extubation.
Thanks, John. In your opinion, does the doctrine of double effect apply in this case?
No, after a careful review of Ms. Castle's medical records, it again does not support the application of the doctrine of double effect. Although I certainly do support the decision of the treating physicians to determine that she was terminal and to allow natural death to occur given her advanced age and underlying medical conditions, I cannot justify the doctrine of double effect in terms of administering the fentanyl, 1,000 micrograms, and the Versed at the time they were given, since at that point, again, she had been breathing on her own. She clearly was trending towards a natural death. So there appears to be no moderation or proportionality justifying the decision to accelerate her death late in the evening.
Thank you. What actions or lack of actions taken by Dr. Hussel speak to his intent in this matter?
So in terms of lack of actions, obviously the decision for terminal extubation had already been made. So I have no criticism of Dr. Hussel's involvement because he was not involved in that phase of the care. Rather, the criticism revolves around the orders had already been placed, and there were reasonable orders provided for the care of Ms. Castle. The administration of the incremental doses of morphine, the availability and administration of the Ativan certainly would have provided an 80-year-old with adequate analgesia as well as sedation during the dying process. Again, there really wasn't an indication that Ms. Castle was in any way suffering from acute pain prior to the progression to the palliative care. And although, again, she did have CPR and one could invoke that there could be some broken ribs, again, the morphine should have been adequate to control that. So in terms of this case, the criticism in regards to what supports the indication of intention is the decision to transition from morphine to fentanyl, and then the excessive dose of fentanyl in combination with Versed after the patient had already received multiple doses of morphine and multiple doses of Ativan, which in the elderly, more likely than not, would result in apnea, would result in blunting of the brainstem's response to both low oxygen, high CO2, and thus cause the patient to stop breathing and eventually for a heart to stop.
Thank you, doctor. I'd like to turn now to the matter involving Rebecca Walls. Did you review the medical records of Rebecca Walls?
Yes, I did review the medical record folder electronically of Rebecca Walls.
And what was her presenting problem?
Mrs. Walls had a history of essentially poorly controlled type 2 diabetes. As a result of that, and perhaps some element of blood pressure issues, she did develop chronic kidney disease stage 4. She also had abnormal peripheral neuropathy. On November 13th, she started to experience nausea, and she suffered from what was described as non-coffee ground vomiting without any specific abdominal discomfort. So she was brought into the hospital, and while there, she was determined to have essentially a pulmonary edema, which is an increase in the amount of fluids that was present in her lung. Additionally, what was determined was that she had not only the increase in the breathing and abnormality, but she had a very harsh murmur in the heart itself that was consistent with abnormal aortic valve function. And that's one of the major heart valves that allows blood to escape the heart. So the thickening and stenosis of that valve caused back pressure in the heart, and that's what caused her to have progressive heart failure and pulmonary edema. So consults were then placed for cardiology and also for the interventional cardiology program, as well as cardiac surgery in order to determine whether she was a candidate for what's known as a TAVR, in which the,
Sorry, what's that word?
oh, it's capital T, capital A, capital V, capital R, TAVR. And a TAVR is when the interventional cardiologist, with backup of the cardiac surgeon, comes through the groin with a catheter, goes backwards up to the heart, and essentially attempts to do valve in valve. So rather than the old-fashioned way of splitting the chest open and opening the heart to cut out the aortic valve, in patients who are elderly or frail, it's a more elegant way of being able to replace the valve from essentially the inside. And they were attempting to work her up for that. Now, when she was admitted, the patient had requested to be a full code. And of course, she was being worked up during the first period of her hospitalization for evaluation to see whether she would qualify for the TAVR.
Okay. And how many days was she in?
Ms. Walls was at Mount Carmel West for 7 days, from November 12th through November 19th.
Doctor, please advise us of the course of her hospitalization.
So in regards to the course of the hospitalization, as said, initially, because she had the problems with the breathing, they were concerned in treating her for congestive heart failure. Unfortunately, it was not an easy treatment because of the valvular problem. So as a result of that, then they decided that they had planned to do a cardiac catheterization on the patient to work the patient up. And in fact, she had an echocardiogram as part of the workup. That was on November the 13th, which showed that her left ventricular ejection was at 40 to 45%. And then she underwent heart catheterization the following day on November the 15th. And what they determined, they did in fact determine she had a bad heart valve, but she had a high-grade stenosis, a blockage in the right coronary artery. So she underwent what is known in medicine as a percutaneous coronary intervention, capital P, capital C, capital I, in which the cardiology puts a stent in the artery to open it up. And that was initially successful, but unfortunately on the next day, they noted that where the cardiologist had gone into her groin, she had a significant hematoma or accumulation of blood. Now, when you put a stent into a patient, you have to put the patient on blood thinners because otherwise the stent itself will clot off. And the patient usually has to be on blood thinners initially intravenously and then orally for approximately a year. The one risk of that is because you're cutting into the artery and the veins of the groin, you can result in bleeding, especially if the plug that is put in there bleeds. So she did experience a hematoma, and there was then attempts to address that, but unfortunately she required intubation, and that then occurred on November the 16th, where she was then stabilized, and they were concerned, although for a pseudoaneurysm, which is a weakening of the wall, but that was ruled out. And then eventually on that same 16th, she required dialysis.
Thank you. What progression of her problems were experienced for the next few days?
So unfortunately for Ms. Walls, her condition did continue to deteriorate. She obviously, given all that had happened, she was not a candidate for the TAVR valve. And eventually there was a discussion made to change her code status. So she was eventually converted to a DNR CCA for the comfort care if there in fact was an arrest. And then in the early morning hours of the November 19th day, it appeared a decision was made at that point to progress to a terminal extubation.
Thank you. At that time, do you believe that the palliative, is it your opinion that the palliative extubation was appropriate?
Certainly, Mrs. Walls had a very complicated medical history. She was at high risk for continuation of medical care. The presence of her severe aortic stenosis certainly would have been a constant threat to life. And at some point, had she survived the initial bleeding episode in her leg and the placement of the stent, she would have required either the TAVR procedure or alternatively the open heart surgery in an attempt to change the valve if she would have had any quality of life moving forward. So any discussion with the patient or the next of kin would have had to weigh the risks and benefits of that moving forward. Again, certainly given that at that point she had at least been stable up to the point of the hematoma forming and the subsequent, it certainly could have also been justified to continue supporting her to see whether or not her underlying organ function would have stabilized.
Thank you. Have you reviewed the pain scoring for Mrs. Walls?
Yes, I did review the pain score.
May I approach you? Share the pain scoring, which is found in the record at 560 to 562.
Thank you.
What level of control, if any, was being achieved of her pain and discomfort?
So from the time of admission on November 12th up through November 15th, she had either a 0 pain score or no indication of the pain score. On or around the 15th, when she went for the procedure, she then did have a documentation of variable increase in pain scores that were documented by the nursing staff. I saw entries of 8 and 10 included. And then it appeared that that was able to be brought under control with the orders that were placed standard in her chart, because by the 16th, it appeared that there had been reasonable control of her pain moving forward over the next couple of days, with just intermittent reports of pain up until the time that it was decided to progress to palliative extubation.
Did you take note of any other scales or scores relating to her person and appearance and or affect?
Yes, my recollection of her chart is that the nurses did document the Richmond agitation scale in her record. So there were other techniques and scoring scales that were utilized by the nurses during our hospitalization.
At the point of extubation, would the 1,000 micrograms of fentanyl and 10 milligrams of midazolam noted in your report have been an appropriate dose?
No, in my professional opinion, given Ms. Wall's underlying cardiopulmonary status, as well as her relatively advanced age, the decision to administer 1,000 micrograms of fentanyl combined with the administration of the Versed, in this case 10 milligrams, would appear to be excessive.
Is there any legitimate medical reason for this dosing?
No, in my professional opinion, having reviewed Ms. Wall's medical record, and again, knowing that her underlying cardiac status had not been completely addressed during this admission, I would see no justification medically to administer these medications, the fentanyl and Versed, at these elevated doses, even if the decision to proceed with palliative care and withdrawal is justified. But these particular medications are in excess of what Ms. Walls would have required.
What purpose could this dosing serve at this level?
So there's no medical justification for fentanyl at 1,000 mics or the Versed at 10 milligrams. So I am forced to conclude that the only purpose of these medications administered at these dosage would be to blunt Mrs. Wall's ability to breathe and thus impair her ability to support her ventilation or to respond to drops in oxygen or elevations in carbon dioxide, which would then rapidly accelerate her demise and lead to her death based on both the pulmonary but also cardiac decompensation that would occur in that situation.
Thank you. Is it, in your opinion, does the doctrine of double effect have application in this case?
No. Given the review of Ms. Wall's medical records and her progression throughout the hospitalization, certainly the end-of-life intervention here does not support or justify the doctrine of double effect. As mentioned, she really did not have consistently elevated pain scores, particularly at the end of life. She also, other than the underlying cardiopulmonary dysfunction, she did not appear to have any terminal cancer that could have caused significant pain or dysfunction. So again, I believe that the doctrine of double effect is not applicable because there was no attempt at moderation in the dosing, nor was there any proportional administration of the fentanyl and Versed that in this case was more likely than not to lead to her death as opposed to simply treating her pain or suffering.
In your opinion, did the dosing of the fentanyl and Versed cause her death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, the decision to administer 1,000 mics of fentanyl in addition to the 10 milligrams of the Versed did cause and or contribute to her death by means of suppression of her respiratory system that then led to cardiac standstill and her ultimate death.
Thank you. What actions or lack of action by Dr. Hussel speak to his intent in this matter?
So in this particular case, once again, there did not appear to be the involvement or integration of all the treatment teams that had been providing care for her. Clearly the medical record details very careful evaluation by cardiology, by interventional cardiology, by cardiac surgery for the workup of this potential valve surgery. I could find no record that they were involved in the ultimate decision-making to determine she was terminal and withdraw. Again, there was an absence of input from the palliative care service as to what options she might have regarding end of life, whether that be transition to home hospice or potentially even to an inpatient hospital to allow natural death to occur. And then in terms of a proactive manner, the decision to administer fentanyl and Versed at these doses in the evening hours at around the time of the terminal extubation would imply the intent to impair the patient's ability to breathe effectively, which given her underlying cardiac frailty and the severe aortic stenosis, it would be known that that would rapidly result in the patient's death. There would be no way that a patient who has critical aortic stenosis could tolerate significant acidosis or an impairment in oxygenation for more than a brief period of time, and that's what occurred in this case.
Thank you. I'm turning now to the matter involving Melissa Penix. Doctor, did you prepare a report on the death of Melissa Penix?
Yes, ma'am, I did.
And did you review her medical records?
Yes,
Prepare that report.
Yes, I reviewed Melissa A. Penix, spelled Penix, his medical record prior to initiating both or writing both the first and then the subsequent individual report.
Okay, thank you. At the top of the beginning page of your report, there's a history and physical. Can you talk a little bit about her overall condition and presenting issues at the hospital?
Correct. So it was well known to Mrs. Penix's treatment team that she had underlying coronary artery disease. In fact, the medical record reflects she was at advanced age, 82, and she had multiple cardiac stents. As a result of having those stents placed inside the heart itself, in those blood vessels, as was mentioned earlier, she needed to have blood thinners for a prolonged period of time so that clots wouldn't form inside the stents. And the standard treatment was low-dose aspirin and the antiplatelet medication known as Plavix. Now, additionally, 2 months prior to this hospitalization, in September of 2018, she had developed an irregular heartbeat known as atrial fibrillation, in which the upper part of the heart, the atria, begin to quiver. When that occurs, blood can essentially congeal within the atria, and it predisposes the patient to stroke, because if those blood clots in the left atrium break loose, they'll go through the pumping chamber of the heart, the left ventricle, out the aortic valve, and they can go straight up to the head. So her doctors had added a third blood thinner, Eliquis, to the patient's regimen. The problem for Ms. Penix is now being on 3 anticoagulants, there was an increased chance that the patient could bleed. And in fact, that's what appeared to happen. She came in with a complaint of worsening shortness of breath, and also particularly when she exerted herself. And there was also concern that she had been spitting up small amounts of blood that likely were related to the fact that there was abnormality in the lung. And you can see, if you scroll down here under admission diagnosis, it listed that there was a pneumonia, that she had both acute and chronic heart failure. And where I've written number 3, report of hemoptysis in the setting of anticoagulation, that infers the spitting up of blood. That often is the secretions coming from the lung. And then there was concern that she had a candida infection inside the esophagus, the previously discussed atrial fibrillation, and then some chronic medical problems. So the plan was to start her on antibiotic therapy, to obtain a gastroenterology consult, to evaluate, to withdraw or take her off those blood thinners, particularly the Eliquis, to see if that would control the bleeding. And I believe she was initially also, besides the antibiotics that I discuss on page 2 of the report, that was prescribed, the aztreonam and vancomycin, she was given some injectable forms of steroid to try to control any inflammation within the lung itself. And she remained in the step-down unit until November the 19th.
Thank you. What happened then?
So on the 19th, her condition began to deteriorate, and it was ultimately determined that she would require intubation if she did not benefit from or tolerate non-invasive modes of ventilation. So in essence, various face masks were applied to her face, and they tried positive pressure ventilation prior to putting a breathing tube in. And as is listed on page 2 of the report, they attempted what's called AIR, AIR/VO, or BiPAP, which is bi-level positive airway pressure. It almost looks like when a jet fighter has that mask strapped to her or his face, and you're trying to not only blow oxygen, but pressure into the lung in order to avoid the patient having to be intubated. They did send specimens from her lung, which is where they describe what's known as a biofire, and they didn't determine any specific cause of the deterioration. So they transferred her to the ICU, and it was decided that she would be intubated and put on the ventilator to support her. Additionally, because she had not been, or she had required the face mask, clearly you can't eat when you're on the face mask. So there was also some nutritional concerns. And of course, they had, along the way, also consulted cardiology to evaluate her underlying cardiac status.
Thank you. Did you review the medication administration record and pain scores for this patient?
I did, yes, ma'am.
May I present? Pain scoring.
So early in her admission, she did have complaints of pain. That was noted by the nursing staff on November the 15th into the 16th. Then it appeared that her pain began to be better controlled, and on the 17th and 18th, her pain score essentially was brought to 0. On the 19th, she had one entry shortly after midnight with a pain score of 2, but then for the remainder of the 19th until the late evening, she was a 0. At around 9:46 p.m., she had one entry of a pain score of 5, and then again, the remainder of the pain scores thereafter were none, or on the morning of November 20th, there was an entry made by nurse Marcy Zent that the pain score was not done because the patient was severely lethargic. And then thereafter, the pain score remained 0 until 5:50 in the afternoon, when there was one entry of 9, but then thereafter, the remainder of the entries were 0 up until 10:48 in the evening when the last pain score was done. And that, again, included a pain score of 8. And it appears here that the initial pain scores that were documented, unlike some of the other patients I've discussed, were what was described as a verbal intensity score. So early in her admission, she did not have a breathing tube, so the nurse could ask her what her pain score was. And then later, once she required the subsequent support, they obviously couldn't ask her and they had to modify the pain score.
Thank you. And for the record, the pain scoring is 472 to 474. The MAR is 708 to 748. Doctor, could you please review the medication administration record in this matter and advise us of the opioid or other narcotic load or orders that were being administered to Ms. Penix?
So in looking at Ms. Penix's MARS, I see the first entry for an opiate is indicated, entered on November the 16th at 9:30 in the morning, where there was an entry for the continuous release form of morphine, and it was administered at low dose, 15 milligrams per tablet. And that was then documented and again related to what was identified as a pain score of 7, and she verbalized that the pain was identified as being back pain. Then it appears that the next entry was that evening of November 16th, where she had been prescribed the morphine CR, or continuous release, 15 milligram tablet, also known as MS Cotton. And here she was administered the medication, again, for a pain score of 8, although there was no location of pain. Then the next entry was on the following day, where on the morning of November 17th, she once again received morphine CR 15 milligrams for a pain score. At this point, she identified a pain score here, a verbal pain score. It says the pain score was 0, but it appears that the morphine was in fact ultimately administered to the patient. And then the next entry that we have is on the evening of the 17th, where she received her standard dose of morphine CR 15 milligrams. Again, in this particular case, at 2100 hours or 9 p.m., it looks like there was not a specific attribution of the pain score. In fact, the pain score was 0 at the point. And yet on the following page, it says pain relief with medication, which was somewhat incongruous that she didn't have pain, but yet it was relieved. Then the next entry was on the 18th at 9:37 in the morning. Again, it was morphine CR 15 milligrams, so no dose escalation. Her pain score at that point was described as a 0. Later that night that morning, there was confirmation. Her pain score was a 0. She was described as awake and alert. Her pain was described at that point as acceptable, and she had achieved adequate pain relief. And then the next entry regarding morphine CR was on the early morning of November 19th at 27 minutes after midnight. And in here, what was entered was that the medication was not given, and there's actually typed in to the record already compromised respiratory status. So the nurse, in this case, it appears to be Robert Kopp, K-O-P-P, did not administer the medication, which was certainly appropriate, given, as he said, that she was showing signs of respiratory compromise. And then the next morning, on November 19th at 8:20 in the morning, there was, again, another entry for morphine here. This was for the 15 milligram. Her pain score was 0. And at least there's an action detail by nurse Hannah Huckleberry at 0822, inferring that the morphine was at least pulled from the system. And then on the next page at 9:02, the same nurse indicated that there was acceptable pain control and that the patient was sleepy but easy to arouse. And I think that may summarize all the entries. Oh, I'm sorry, there was one more here, and that was on the evening of November 19th at 9:46. Again, there was a pain score assigned using the COP protocol of 5, and it was indicated that the nurse, in this case, Corey Fleming, drew or pulled out of the system the morphine, And then on the subsequent page indicates at 22:46 that the medication was given and that it appeared to have relieved the patient's pain, and the patient had an acceptable pain level and was sleeping. And then on the following morning, there was an entry on November 20th at 9 a.m. Regarding the morphine, and here Nurse Marcy Zent says that no administration of medication was given because the patient was lethargic. And then the next description of any form of narcotic was on November 20th at essentially the initial entry was at 5:50 in the evening, and then it was charted at 7:58, and it describes the administration of Dilaudid 1 milligram to the patient, ordered by Dr. Gandhi, Gandhi, and there was a narrative addition there by the nurse saying that Miss Penix had experienced severe pain. And below that was a description of the patient receiving Haldol, which is an anti-agitation or antipsychotic medication. And she received 2.5 milligrams of Haldol secondary to agitation. And then shortly thereafter, 9 minutes later, at 6:05 p.m., the patient received, or is this a follow-up? This may be the follow-up to the Dilaudid entry that was given earlier, where it describes that the patient is sleeping. And then...
You're on it. I see. This whole time he's been reading, I
agree.
fail to see where we're answering a question.
Let's ask a question there, Counselor.
Thank you. Doctor, can we address our attention to the time of the intubation in this matter and what medications were used at the intubation?
Yes, so on page 11 of my report, it indicates that the patient was intubated by Dr. Douglas Closer, C-L-O-S-S-E-R, and the procedure occurred at approximately 8:11 in the PM, and it was described as an emergency intubation. The patient received 100 milligrams of ketamine, as well as 2 milligrams of Versed.
Thank you. At some point, did this case progress to a code status change?
Yes, at some point, the patient did progress to a code status change. Again, the patient had other interventions, including the placement of an arterial line for blood pressure monitoring, as well as other medications being administered. But then we see that there was a discussion about changing the code status to DNR comfort care.
Thank you. Do you feel, or is it your opinion that Mrs. Penix had any survivability reserve?
Yes, within a reasonable degree of medical or medical certainty, given her presenting symptoms that this was related to the blood thinners that had been administered to her because of the stents she had placed and the fact that she had a pneumonia in her lungs that required treatment. Certainly, she had not reached the point of terminal status. Also, she had just been intubated with the breathing tube placed. And so in terms of support, there really had not been ample time to determine whether or not the addition of the breathing tube, but more importantly, the addition of the ventilator could successfully support her lungs and give the antibiotics a chance to correct the infection, and the other elements of her treatment to correct the underlying metabolic problems.
Did this patient have paralytics administered?
Yes, the patient received paralytics, but apparently not for the intubation. Subsequent to the intubation, the patient was ordered 2 separate paralytics. The first is a drug called Nimbex, capital Nimbex, which is, again, it's a skeletal muscle relaxant, and that was ordered on an infusion, and for the patient to receive 3 micrograms per kilo per minute, and to be increased according to the order by 0.5 micrograms per kilo per minute every 15 minutes until adequate paralysis was achieved. And the patient was also ordered a bolus dose of vecuronium, which is a paralytic from another family. So they're both muscle relaxants. The first, the Nimbex, is essentially a benzyl isoquinolone, and then the vecuronium is in the family of steroids. So those are 2 separate drug categories, and you usually don't want to mix them, because if you do, you can dramatically prolong the period of muscle paralysis.
Thank you. And at what time did this patient proceed to extubation?
So the patient proceeded to extubation. There had also been an order to increase the Nimbex that was listed on the bottom of page 16 of my report. And then one sees the entries for the medication in the medical record. Let me just find the entries here. Again, I'm just going to refer to the MARS to get the specific timing. So there was an order placed at 10:48 for 2,000 micrograms of fentanyl by IV push. And then 1 minute later, at 22:49, there was an order for 10 milligrams of Versed to be administered.
Was that, who ordered that?
Those 2 orders were placed by Dr. Hussel.
Does the administration record show that they were administered?
Yes, it indicates that those orders were followed by Nurse Wesley Black, B-L-A-C-K, and that the administration or action details occurred within a minute of the order being placed and occurred at 10:49.
In your opinion,
It's getting late. Do you have a lot more?
I can wrap this up by 5, I think.
Okay.
I know we're coming, you know.
We got some people giving me this over here.
Oh, we can, I mean, whatever you
You
want.
guys need to stop?
Judge.
Yeah, I see one.
Judge, we need to approach before we break for the day.
Okay.
It needs to be here. We may.
Let me have a sidebar and then we'll get you guys to get to you, okay? David?
Okay.
Yeah. Unless he goes out. then maybe we-
Geez, they're still going with this guy. I mean, I just got out of a last minute court case. Court called me if I'd take an appointment for a guy. Oh, thank you, Seabreeze. I appreciate it. Yeah, I've been listening, and I can understand why people are now leaning towards finding the, going towards, well, maybe Hussel did this and he is guilty. I'm just not really sure if that's still enough yet. But I can understand why. Yeah, he's reviewing each of them, and yeah, I assume this is their last witness. He's going to wrap all of them up, explain why all of these are bad, and why he killed all of them. But I still think, given the nature of medicine, also, did the defense get to cross-examine him yet or not yet? I apologize, guys. I barely had time to say hi today, so I don't know. Okay, so this is still on direct. Yeah. I mean, remember, he's got to survive cross, and remember what happened every time we're on cross. Pretty much everybody looks like an idiot. Now, I doubt this guy will. He seems very knowledgeable, but it'll be interesting to see. I'm assuming Jose is going to do this one, how he comes at this guy. Oh, hold on. Lori says, they went a long way to find this doctor out of Tampa, out of Florida, my state, that works in Tampa. Would have been teaching interns while they died. Sorry, it's my opinion. No. Guys, this is have any opinion you want. This is, you don't have to apologize for any opinion. That's how this works. We talk. We figure stuff out.
Okay, I have to discuss something with you, ladies and gentlemen of the jury. Somebody involved with the prosecution of this case has tested positive for COVID. Okay? I don't think they were around any of you, and if I remember correctly, everybody's vaccinated on the panel. Is that pretty right? Is anybody not? You? You? Okay. Huh?
I had COVID.
You had the COVID? Okay. You've been clean this whole time, huh? Okay. We do have incident tests. You won't show any signs for at least a couple of days. Okay, so we're going to carry on tomorrow. If any of you want to run to the doctor, let me know right now and we can adjust the time schedule. But I brought each of you up individually. I offered you an opportunity to talk to me about COVID, and it's one of those things that sat in the background. I don't think you guys are in any danger right now, okay? But we have to be careful, okay? Why don't we meet at 9 o'clock in the morning unless anybody objects, okay? We'll keep on with the continue the testimony and get through the doctor, okay? Okay, I want you guys to have a good evening, okay? Don't worry about it. If you show any symptoms in the nighttime, please let David know. I think you got his cell number. Okay? You know, this isn't a time to be proud or hide things. Okay? You know, we lost a lot of people around the courthouse to it when it first came down. So we take it very seriously. Nobody involved with this case, but, you know, A lot of people lost their lives, so we take it seriously. If you get the sniffles or anything, I understand that. I've had the sniffles during the trial, it was a cold. But I tested myself. If you guys need incidents, I can have David bring them to you tomorrow so that you have them for the weekend. Okay? Because taking an incident now isn't going to do you much good. They say 4 to 5 days after you've been exposed. It's not the case. Okay? But we can probably, if you guys want them, just tell David, he'll get as many as you guys need. Okay? Hopefully. Knock on wood, the government working right. Okay? Ladies and gentlemen, anything for the record before I excuse them?
Nothing, Your Honor.
Ms. Menashe?
No, you don't think you.
Okay, ladies and gentlemen, have a wonderful evening. Talk to David if you want something. Okay? We assure you, this place will be disinfected tonight. Somebody's water bottle. Okay, let's finish up the record here. If I remember correctly, when Mr. Bias alluded to her health, she was masked the rest of the day.
She didn't come back, Judge.
She didn't come back, she went and did the incident, didn't come back.
No, she just went home, yeah.
We sent her home.
That was at 4 p.m., roughly in the late afternoon, I think.
Middle afternoon, yeah.
Yes, I was giving that.
Because it was on the first break that you mentioned it in the afternoon.
Yes.
Okay. Anything else for the record then?
Not from the state.
Nothing, Your Honor.
If anybody is feeling ill, please notify us. Okay?
Yes, sir, thank you.
We gotta take as many precautions.
We don't know yet, though. One more second, guys. Hold on. Can't. So, yeah, looks like somebody had an issue with COVID. Maybe one of the jurors, it sounds like. So, remove. Why won't this let me? Oh, start cam. Yeah, guys, sounds like there was an issue about something on the jury. Sounds like COVID outbreak happened. Somebody got sick. They're no longer there. Yeah, that's the big concern, because imagine that if they lose enough jurors, they got to restart. So, not good for anybody. So we shall see. Oh, prosecution team member has COVID. Okay, I misunderstood that. I thought it was a juror. Yeah, somebody on the team has COVID. Well, yeah, I can see whether it's a problem. So, now that can hurt them. It depends on what they were going to do and what part of it they were going to, look into. Yeah, sorry guys. Prosecution thing, thank you for clarifying. But yeah, that's kind of the way things go in this world now. People get COVID. The judge, I think, was doing his best to make sure nobody in the jury panicked, because what he needs now is
not a panicking jury who refuses to come in because they're afraid of COVID. So they have access to test kits. It sounds like they're all good to go. So, yeah. So I know some of you guys were. Actually, I want to see, what did the poll turn into? I left that poll up for a while to see if you guys might change your mind or something would happen there. Let's see. Okay, so I kind of figured the last vote, please no more doctors, would get a good portion of everybody who watched. Because I'm almost to that territory. I don't care anymore. I just don't want to hear any more doctors talk about. No, they're not going to have to quarantine everyone. I think it was done, well, this is kind of the point nowadays. COVID's, a thing, but also this judge is not going to sabotage the trial. So, they're going to finish this goddamn trial before that happens. I can guarantee you. Be ironic if that person ended up intubated and needed palliative care. Yes. Yes. What a twist. That'd be very, very ironic. Maybe Alanis could write about that one. Isn't it ironic? So, yeah, just wanted to mention that. Yeah, but hey, a lot of people did die in Columbus. For some reason they hit really hard there compared to other places. So, but yes, he could have left that out. But the new part when you're a judge, don't have to give a fuck. So that's the best part about being judge. You can do whatever you want. Yeah, and then they have palliative care. But yeah, so that's where we are. Looks like we'll start up tomorrow. Maybe there might be a day or two break, but that would be it. I don't see it happening. So yeah, it'll be interesting to see what this happens on cross for this guy. He does seem to be a little more. I trust his medical opinion a little bit more than I trust Dr. Ely's right now. So we shall see what happens. I think it'll be interesting. So yeah, I will. I'll keep this poll in mind because I'm curious to see how things change later today or tomorrow. Things go because, like I said, I'm a very inquisitive person, so it'll be interesting. Ooh, long crime poll was 65% not guilty. Well, that's the other thing, Zulu, and I don't know if you've been here when I've mentioned this before, but this is not just there's a lot going on here in this case. There's a lot of undercurrent. Yeah, professional paradigms driving it. Yeah, there's a lot of layers to this onion. So we'll see what that turns into. I think I just think it makes things more interesting for what happens. I did want to say while we're all here, because I'm not going to be on for too long, because I actually have a kind of a last minute thing, emergency I have to take care of. Tonight at 11 p.m. Central Time, I will be on with Nick Ricada. So if you guys are interested, I will be on then. So 11 p.m. Central, which means if you're out on the East Coast, that's midnight. But I just want to let you guys give you a heads up. Didn't want to surprise you. In case any of you are actually going to stay up that late. Matthew, I know you can wake up first thing in the morning and watch me. So, yeah, guys, and that's really it for today. Midnight. I don't make it to midnight much. I know, Critter. I know a lot. I know a lot of you guys might not make it, but wanted to give everybody the heads up. Kitty's in the room with me. Got locked in. So, yeah, you will be there. It's an early alarm for you, but hey, at least you're not waking up at like 2 in the morning like you have been other nights. So, better than your Thursday. So, yeah, guys, I think this one, this is their guy who's meant to bring it home. Still sounds like there were some issues about expert reports not being properly provided, which, once again, that's a big deal, and the appeal ground is getting laid out. So, this is only 14 out of 45 people. That bothers me. Well, how many are watching right now? Well, there's 12 watching. Appreciate the likes, guys. Oh, 35 votes. So, yeah. It's getting there. So, all right, guys. Well, I'm going to call it a day for today. Oh, there's only 14 out of 45 deaths. I see what you're getting at, impression. Yeah. Well, yeah, 45 deaths. I think that shows you how much of a question there is on the rest of these. That they can't tell. And that there's so much going on. Once again, this hospital was a mess. Every level of it was junk. Sounds like there were problems with the doctors, there were problems with the nurses, the pharmacists, the administration. Sounds like the only people who didn't have a problem were the guys changing out the bedpans. That sounds like they did their job right. Thank you. So, that's really it. Like I said, 14 out of 45, that's, it would be insufferable Zulu, but at least they know all 45 are legit. 14 out of 45 shows we don't actually know, and a bunch of them are sketch. Which means compared to these ones, which are a little iffy, what are the rest of them at? Something you have to think about. So, all right, guys. Well, that's it for tonight, and we'll see you tomorrow morning, or I'll see you tonight. Have a nice day. Okay, some did settle out of court, but settling out of court has nothing to do with the criminal case.